Okay, so yeah, go ahead with your question, and then I guess we'll wait for everybody else to sign on, and we'll do some housekeeping.
Okay, my question is on the question you asked when a patient is having in-hospital DNR but not an out-of-hospital DNR.
Okay, so can you see my screen share with the test?
What's that?
Can you see the screen share? Can you see the test up on the screen?
I can bring it up.
No, I have it. Do you guys see it?
No, we just see you now.
Okay, hold on.
Yeah, it's not on. It was on earlier.
Okay, hold on. Is it on now?
Now it's on.
Yes, now it is.
Okay, so this is the first question somebody had. So it says, first of all, I didn't word it so nice, but let's go through it. You are transporting a patient home from the hospital who has an in-hospital DNR. So that's actually a term, in-hospital versus out-of-hospital. So an in-hospital DNR is a DNR that's issued to a patient when they're in the hospital, and it covers them from the time they're in the hospital until the time they get home. So it actually covers us for the transport home.
Okay.
Okay, so that's the deal there. So that's why the patient went into cardiac arrest en route to the house.
Bring her back to the hospital to pronounce.
So only the way home, not the way in.
No, it would only be from the hospital to the house.
It's not that once he's out of the hospital, then he's then it's not anymore DNR.
Right. So once he's out of the hospital, he has to have an out-of-hospital DNR filled in. So the in-hospital is only good in the hospital, and the out-of-hospital is good, you know, with the whole time he's out of the hospital and then going back for the ride back to the hospital.
Right. So the in-hospital is good until he gets home. Until
Yes.
Okay.
So Frank, so this DNR is a specific DNR that like the MOST, or it's like a basic DNR? Because on the DNR you got to see which one is a in hospital, which one is out of a hospital, or
No. So in other words, if you were going to the hospital, I'm sorry, I'm just trying to figure out how to use my volume. If you were, hold on one second. I just don't see my volume controls. Let's see.
I guess I'm drinking. Okay.
So if you were doing a transport home from the hospital, this would be a document they would give you in the hospital for your trip home. If you were at somebody's house who had already been home and they were enrolled in a hospice program, you know, like a program for people that have come home to die, then they would be giving you an out-of-hospital DNR.
So when people have an old age home, that's called out of hospital?
People have what?
An old age home. Let's say I was on a call in Friedwald and there was a DNR over there. That's called the out of hospital one?
No, that would be in hospital, because a nursing home and a hospital are covered by the same law.
Got it. So that's in hospital.
Right. The only thing that would be out of hospital is a home.
Okay.
Then you had a question about if he had a DNR in the date in 2002.
Okay, so let's go through the test. I have the test up here, so I know that you know, probably everybody wants to go through the test. So the first thing is, I didn't give you the test to you know, stress you. I gave you the test just to, one, so everybody sees where they're at and I can see where everybody's at. The second thing is I want people to realize that just listening to me teaching is not going to be enough. You have to open that book and you have to read the chapters in the book, right? So right now we're on anatomy and physiology. So everybody should be reading that chapter, because just listening to me, you're not going to get the same information as, you know, reading the chapter. And trust me, if you read before you come to class, what we talk about in class will make much more sense. So try to, you know, not try, but open that book. You know, you spent money on it, and you know, get cracking with the material in the book. Okay. Okay, so let's go through the test. Oh, so the other thing I did is I emailed out the test to you, so you now have the test yourself in your email. The other thing I did is I didn't redo, but I modified the handout for the anatomy and physiology. I just made it a little clearer. So I also emailed copies of the handout to you guys. And again, there's one file that has each page individual, just like when you're looking at it on the screen, and it's in color. It's just it's a big file, and I wouldn't print it out because it would cost a fortune. The other file is in black and white, and it's 3 slides to a page. So that's a little easier to print out on your own personal printers. Okay, so let's talk about this. What is the recommended next step after defibrillation attempt? So we always said that after we defibrillate, the AD is going to tell us to do what? Go right back into
CPR.
CPR. Okay. And the rationale for that is that if the patient were to wake up, if we were to save them and the patient were to wake up, then we would know that we don't have to do CPR on them. And if they don't wake up, it's one of 2 things. That one, we did put them into a normal rhythm, but that blood pressure that normal rhythm is generating right now is not enough to wake them up, so they would benefit for some chest compressions, or that they're still in cardiac arrest, they're just not in ventricular fibrillation, which means the AD is of no use. So that's why we're going to continue to do CPR for 2 minutes until the AD reanalyzes the rhythm. Okay, so number 2, the EMS team arrives to find a 59-year-old guy lying on the floor. You determine that he's unresponsive. What's the next step in the assessment and management of this patient? So a lot of people have problems. Right. So a lot of people have problems with this. A lot of people pick A before D. And I wouldn't say this is a tough question, because if I was the person, answering this, you have to open the airway to check for breathing. So that's how I would argue that A is the right answer. But the way CPR is set up now is they don't want people to take a lot of time assessing the patient. So they pretty much say all the time, just assess breathing and pulse. They don't talk about necessarily, opening the patient's airway, even though it's something we have to do. They don't necessarily talk about it too much. So on this test, the right answer was D. Okay. So this, we didn't really do this chapter, but this is one of the chapters in the early part of the textbook that's talking about, it says like the well-being of the EMT, like taking care of how the EMT takes care of themselves. Like usually we worry about taking care of other patients, but this is talking about, taking care of us. So, obviously being an EMS, you could have a very stressful call, like that horrible call on the thruway with Moishi and David, where they rolled the car over and the car caught on fire. So those guys that were there, obviously they had a lot of, stress to deal with. So it's asking you, what are some of the signs and symptoms of stress? Okay. So really, inability to sleep and insomnia are the same thing. So insomnia means you have trouble sleeping, and inability to sleep obviously means you have trouble sleeping. So those are the same thing. And decreased appetite. So those are all considered to be signs of when people are stressed. And, it doesn't have to be something horrible. I mean, if you had a deadline at work and you had to, get a lot of stuff done and you weren't sure you would get it done, these are all things you would experience also, right? You'd be having trouble sleeping because you'd be thinking about it. You didn't want to take time to eat and stuff like that. So, so just so you know, the first, let me just check now. So question 1, 2, and 3 were all state exam questions. So I'm trying to include to you questions you'll see on the state exam for 2 reasons. It may not be material that we're necessarily spending a lot of time on, but it is important to review, and also so you see the wording of the way the state asks questions. Okay, so this was a freebie question, right? The correct rate of CPR on a 6-year-old patient. So we know that the rate of CPR is the same no matter what the age of the patient is. So all CPR is done at 100 to 120 compressions per minute. Okay. And if you have any questions, just interrupt me. Okay. Which of the following advanced directives can be honored by EMTs in New York State? Choose all the correct answers. So an advanced directive, again, some people ask me, what's an advanced directive? An advanced directive, again, is when a patient puts their healthcare wishes in writing, okay, ahead of time, before they have an emergency. And in New York State, we have a lot of different types of advanced directives. Actually, all of these are advanced directives in New York State. Okay, but the only ones that we could honor in the field as EMTs would be a out-of-hospital DNR, so it'd be C and D, a MOLST form, medical order for life-sustaining treatment, and a New York State Department of Health out-of-hospital DNR, okay? And, yes, you could say if it said a in-hospital DNR, we could honor it on the way home, but that wasn't one of the choices, okay? So those are the ones that we can honor. And the reason we can't honor A and B is both of these require that a doctor certify that the patient's not able to make decisions for themselves. Even though obviously in a cardiac arrest, nobody can make decisions for themselves, because the law says that a doctor has to certify them. And since there's no doctor with us, that's why we don't honor A and B. okay? But if these are properly filled out, you would want to bring them, again, you're not going to know that they're properly filled out, but you're going to want to have the family bring these to the hospital, because in the hospital, they will honor these. We just can't honor them in the field. Okay, question 6, you're dispatched to a party not breathing. Upon arrival, you find a 72-year-old male on the floor in cardiac arrest. Family states the patient was last seen 8 hours ago. The family presents you with a properly completed New York State out-of-hospital DNR that was signed in 2002. What should you do? So if you remember, I said that any of these advanced directives never expire. They do have on them that they're supposed to be updated every 90 days, but it does say that even if they were not updated, they're still valid. So as long as the person who issued them doesn't rescind them, doesn't say they're not valid, they're still valid. So an expiration date doesn't count. So the answer to here would be A, not to start resuscitation, okay? Question 7, what we just did, we're transporting a patient home from the hospital as an in-hospital DNR. No out-of-hospital DNR has been issued. While in the ambulance, the patient goes into cardiac arrest. So again, an in-hospital DNR is a document that's issued by either a hospital or a nursing home, okay? And it covers the patient when they're in the hospital, okay, to the ride. I'm sorry, they covers the patient when they're in the hospital and for the whole ride home, okay? So for the ambulance standpoint, it covers them for when we're taking the patient home, okay? So in this situation where the patient went into cardiac arrest in the ambulance from the hospital to the home, we would not start resuscitation and we would bring the patient back to the hospital. Okay, so it would be D, withhold resuscitation.
What's the difference in CPR and resuscitation?
Nothing, same words.
Okay.
No difference.
Sure. Thank you.
So resuscitation would be the process of trying to bring somebody back to life. And obviously CPR is part of it, the AED is part of it. So, you know, resuscitation is like the broad term. And then there's individual things that you would do inside of it. Question 8, you respond to an unconscious patient who you find to be pulseless and apneic. So pulseless means obviously no pulse. Apneic is the medical term for not breathing, okay? So again, if we went back to when we did medical terminology, right, there's always one part of the word, usually the beginning part of it, and then there's the other part of it, right? So there's the prefix and the root. So A, I said A or AN in front of a word usually means that it's something's not there, like asystole means without a rhythm, right? So apneic, A in front of the word, and then PNEA, again, it's a little different here, but is breathing. So this means not breathing. Apneic or apnea means somebody who's not breathing. So this is a patient in cardiac arrest because they have no pulse and they're not breathing. Okay. So while examining the patient, you find a purple discolorization on the small of their back and the back of their thighs. So if you remember what we were talking about when we start CPR and when we don't start CPR. So we said the first thing we want to look for is to get some kind of idea if the patient has been dead for a long period of time. And there were two things that we mentioned to look for. There was dependent lividity and there was rigor mortis. So let me bring up something. Okay, whoops. Okay, can you see this this picture over here? There's a dead guy on the right side of the screen. Can you see this?
Yep, we see it.
So what happens when the body is no longer pumping blood is blood will flow or blood will pool in the body to the part of the body that's closest to the ground. So since this guy was laying on his back when he died, the blood pooled, and since he's light-skinned, you know, he's a white person, you'll get a purplish discolorization, almost looks like a bruise on the part of the bodies that's closest to the ground. Now, what's interesting to note is that on his buttocks and on his shoulder blades, because they were pressed on the ground, blood was not able to get there as much. So typically they don't get that purplish discolorization on their buttocks and on their back. Now, if he were laying face down, the bruising would be over his, probably not his chest, but over his belly, okay? and maybe his thighs, the other side of his thighs and stuff like that. So wherever they're laying, that's where the blood would pool. Now this typically happens 20 to 30 minutes after the heart stops pumping blood. So if you see this, it means the patient's been down at least 20 to 30 minutes, which means there's no chance that their brain is still able to be saved. So there's no purpose in resuscitating them. So this is the first thing you would see. And then let me show you the, well, actually this guy has the second thing, which is called rigor mortis. Rigor mortis means that the muscles in the body start to get tight. So if you look at his arm.
Can you please unmute everyone?
What's that?
Mute. Can you please mute everyone?
Can I please what?
Mute.
Okay. Okay, so you could see that his arm is getting rigid, right? His body's getting rigid. So that's the second thing that you would see in somebody who is dead, right? So the first thing is the dependent lividity. And the second
This
thing
takes about a half hour after the person dies? Or
yeah, it takes about roughly a half hour. Okay, let me show you this one. Let me just make sure I'm sharing it. Okay, so you see here how the arm is tight and it's not falling down onto the table like it should. So this is, again, this is rigor mortis. Usually the first place you see rigor mortis is in the jaw. So let me see if I can get a picture of that. Okay. Okay, so either they're going to die with their mouth open and you would not be able to close it. So everybody, I'm assuming everybody could see this picture of the guy, this dead guy with his mouth open. If you can't, just speak up. But anyway, they would either die with their mouth open and you would not be able to close it, or more commonly they die with their mouth closed and you would not be able to open it. So if you were to put your hands on their mandible, on their lower jaw, you would not be able to open their jaw. Okay, so that's the first place you see rigor mortis, but you're not going to see rigor mortis without dependent lividity. Now, the only time that dependent lividity may be a problem to see is if somebody's dark-skinned, right? It works best on somebody who's light-skinned.
What means mortis?
What does mortis mean?
Yes.
Dead. Rigor means rigid, and mortis is dead. Okay, so those are the two signs that you would see in somebody in cardiac arrest.
A rigor mortis usually holds only till 48 hours.
Right, but again, after that time, the body's going to start to break down and have smells, and the skin is going to break down. So, I mean, pretty much everybody will know the patient's dead. You're not even going to want to be in the room. So, at that point, you know, it's pretty obvious. So I wouldn't worry about it. You know, mistaking that somebody. I doubt the cops would even. You know, I don't think anybody would even think that patient is still alive at that point. Okay, so now let me get the test up. Okay, so the test should be back up. If it's not, let me know.
Yep, it is.
Okay, so again, this guy, purple discolorization on the small of his back, which is the lower part of your back and the back of his thighs. So in this situation, he's obviously dead. So it would be A, withhold resuscitation. Okay, question 9, you respond to a motorcycle accident, motorcycle into a boulder, that's a rock.
Just have a question. If I don't start the resuscitation, that means that I assume that the person is dead.
It's that you're assuming that the patient has been without a pulse for a long period of time. You're not pronouncing him dead, right?
I understand, but
good.
Oh,
no good.
So basically, I'm not the one that could say that he is dead, but I could determine if I should be working on him or not.
All right, I understand. It's a silly thing, but yes, you're not signing the death certificate. Because again, the way the law was written is that it requires a physician to sign the death certificate. You're just deciding that there's no purpose in resuscitating this person because they're too far gone. They've been dead for too long. So again, don't overthink this stuff, right? We didn't write the laws and we're just, you know, we're stuck operating within the law, okay? So in number 9 over here, we had a motorcycle accident. The motorcycle went into a boulder, which is a large rock. 18-year-old rider was thrown from the bike. Helmet was cracked off his head. Okay, so if you know anything, it's very hard to crack a motorcycle helmet. You know, and probably the fact that it was cracked off his head meant it wasn't strapped in place. Okay. Patient has significant blunt trauma. Blunt trauma and penetrating trauma are two different things. Blunt trauma means like somebody punched you. Penetrating trauma means that something like stabbed you or a bullet hole, something entered your body. Blunt trauma, it doesn't enter your body. It hits your body, but it doesn't enter your body. So like this guy crashing his motorcycle into a rock, that's called blunt trauma because the rock didn't penetrate his body. He has significant blunt trauma to his head and his thorax. Remember, the thorax is the medical term for the chest. Okay, we cannot find a pulse because he's in cardiac arrest. Based on your assessment, you determined that resuscitation should be withheld. So is this correct? And the answer is yes. So this guy is what we call a traumatic cardiac arrest. So unless you witnessed it happen, more than likely you would not work that patient because he's in other words, it's not something simple like his heart is out of rhythm that you could shock him back into rhythm. The reason this guy is dead is that his body's destroyed inside, and there's no way we could fix that on the inside of his body.
We spoke about it last time. If he is an organ donor.
Right, but again, because he has such massive trauma, because in this situation he has such massive trauma. Okay, he's not going to be an organ donor. You know what I'm saying? In other words,
okay, let's say if it's less trauma.
So I would not start thinking about, like, I don't do that. Like, I don't say, okay, you know, we're gonna work this guy because of the fact that he may be an organ donor or not an organ donor. I don't. I mean, I don't look in their wallet to see if they have an organ donor card or anything like that. Usually what will happen.
But I'm asking, it's not something that I need to do if
No.
I'm EMT on site.
No, not at all. Okay, question 10. In New York State, EMTs can make a pronouncement of death. So we already know that that is not true, right? That's false. We cannot pronounce death. Okay, dependent lividity tends to occur before rigor mortis. So now we know that is true. Okay, one of the earliest body parts to display rigor mortis is the jaw. So now we know that is true. New York State out of hospital DNRs never expire. That is true. Okay, see how easy it is to take this test? To assure your own safety when lifting a patient is important too. So the most important thing when you're lifting is that you use your legs, not your back, right? That's always a classic state exam question. And I think everybody knows that just from, you know, life in general, is that we always lift with our legs, not our back, which means we don't bend over, we squat down when we're lifting something. When lifting a patient, you do all of the following except. And the except would be, we don't want to twist while we're lifting, just like, you know, when you're lifting something, if you twist, you tend to hurt the sides, you know, muscles on your side. Okay, so 16, EMS personnel who incorrectly force a patient to go to the hospital against their wishes or restrain a patient who did not need to be restrained can be charged with a crime. That is true. Right, so you have to be careful about that. Again, I would not restrain people unless the police are involved and they agree. Okay, 17, the correct depth to compress an adult sternum. That's their breastbone, right, the front of their chest over here. When performing chest compressions is, and the answer is at least 2 inches. Remember, for a child, it's about 2 inches, so you have to watch the wording. And for an infant, it's about 1.5 inches. An adult patient with a foreign body airway obstruction, so that means there's something blocking their airway. And when it's foreign body, they're usually talking about food or a toy and a kid or something like that, right? Because that's something that's not usually in your body. And he's able to cough forcefully. So he has something in his airway, but he's able to cough. So that tells us that all we really need to do is encourage him to cough, because a cough does more to clear an airway than we can do manually. So this would be B, not to interfere and monitor the patient. If at any point he can't cough anymore, then we help him. And since he's, well, it doesn't say he's an adult. Since he's an adult, it would be doing the abdominal thrust, the Heimlich maneuver. Okay, the heart contains how many chambers? So I think everybody at this point knows there's 4 chambers, right? 2 atriums, 2 ventricles. So right atrium, right ventricle, left atrium, left ventricle. The upper chambers of the heart are called atriums. Okay. Carotids are the pulses in the side of your neck. The ventricles are your lower part of your heart, the lower chambers of your heart. And the sternum, again, is the breastbone where we put our hands for CPR. The part of the heart that is thickest and strongest muscle because it needs to pump to the entire body is the left ventricle, because that's pumping to the aorta, which is your largest artery, which is bringing blood to all the rest of the arteries of your body. Okay, the chamber of your heart that pumps blood to the lungs is your right ventricle. So the right side of your heart pumps to your lung, and the left side of your heart pumps to your body. The most common abnormal heart rhythm that adult patients are found in when suffering from sudden cardiac death is ventricular fibrillation. Now, somebody had a good question today. What is the difference between atrial fibrillation and ventricular fibrillation? So just what we just did now, going over stuff, you know that the atrial means the atriums, which is the upper chambers of the heart, and ventricular means the ventricles, which is the lower chambers of the heart. And those of you who read know that the atriums only pump an inch away to the ventricles, right? They don't pump very far. And the ventricles, the right ventricle pumps to the lung and the left ventricle pumps to the body. So just talking that little bit, I think everybody knows that the ventricles are the more important part of the heart than the atriums, right? So if somebody's in atrial fibrillation, blood will still flow from the top of the heart to the bottom of the heart. If somebody's in ventricular fibrillation, they're dead because no blood is pumping to their lungs or their body. So somebody in atrial fibrillation can be alive. Somebody in ventricular fibrillation cannot be alive. Just, you know, the other thing is the student today asked, you know, what's the danger of atrial fibrillation? So atrial fibrillation is a dangerous rhythm, but it's not death. So atrial fibrillation, the danger is that if the upper chambers of the heart are not contracting and emptying completely of blood, so one, you're not pushing as much blood as you should be, so that's one issue. The other thing is that if blood doesn't completely empty out of a chamber of the heart, there's a good chance that the blood will start clotting and they will get blood clots building up in their atriums. And if their blood clots are building up in their atriums and they break loose, they will now float through the body and lodge somewhere else. And again, we don't know this yet, but that's how people get strokes and pulmonary embolisms in their lungs and all different kinds of problems with blood clots. So anybody who's on atrial fibrillation is always taking a medication that prevents their blood from clotting out. It kind of thins their blood down a little bit, okay? We know pulseless electrical activity, PEA, is one of the other forms of cardiac arrest. Asystole is one of the other forms of cardiac arrest, and ventricular fibrillation is one of the forms of cardiac arrest. Ventricular fibrillation is the only rhythm where the AED is helpful in. Asystole, again, remember there's an A in front of a word, so it means there's not, something's not there. And the term systole is the medical term for the heart contracting. So asystole means the heart is not contracting, and that's when somebody's flatline, no activity. Ventricular fibrillation is where the ventricles, instead of contracting and squeezing, are shaking and no blood is flowing, and that's where we defibrillate it to reset the pacemaker and put it back in a normal rhythm. In ventricular fibrillation, there's too many impulses from the pacemaker of the heart shooting out, and the heart can't process it, so it shakes. And pulseless electrical activity means that the electrical part of the heart is working fine. So the pacemaker is sending out impulses like it should. So on the EKG screen, it looks totally normal, but there is no pulse with it. So the mechanical, the squeezing, the pumping part of the heart is not working. Okay, or the pumping part is working and the patient's lost all their blood and there's nothing for the heart to pump. So this is a more difficult one to treat because you have to play detective and figure out what's missing. And again, in the field, you know, outside of the hospital, there's not a lot, even in the hospital, to be honest with you, but there's not a lot to do. Okay, so the lower three, B, C, and D, are all forms of cardiac arrest. And again, ventricular fibrillation being the most common and the one we use the automatic external defibrillator or AED on. Atrial fibrillation is a rhythm that is dangerous to a patient, but not fatal. Doesn't mean they're going to die, and it needs to be managed with medication. Why is allowing for complete chest recoil, relaxation, recoil and relaxation mean the same, important when performing high quality CPR? Okay, so the answer there is that the heart will refill with blood, okay, on the upstroke of CPR. And it's all, again, pressure changes, just like breathing, right, is pressure changes inside your chest, so is CPR pressure changes. And when your chest is coming back up, when the sternum is coming back up, when you're relaxing on the upstroke of CPR, you're creating negative pressure in the chest and it's drawing blood back into the heart. Okay, let's do question 25, and then we'll take a 2-second break to see if anybody has any
Is the
questions.
What's the is the difference when the electricity of the heart works and it still doesn't pump it? If it's fibrillation, does that mean that the muscle is damaged?
Well, so ventricular fib, are you asking what's ventricular? Is the electrical part working in VFib? Is that what you're asking?
Yeah, you mentioned that there is something like that where the electricity still works, but it's still not
That's
pumping
B.
out. Is
That's
that because the muscle is damaged?
So that could be one cause. So what you're talking about, if the electrical part works, if the pacemaker of the heart works, but there's no pulse, that's B. That's pulseless electrical activity that people call PEA. They abbreviated the first 3 letters of the word, PEA. So that could be, okay, a problem with the muscle of the heart. That could be a problem with not being enough fluid to pump around. That could be a problem with the valves between the chambers of the heart not opening and closing properly. That's what I'm saying. It could be a million different reasons. So it's a little harder to be able to figure out, what's going on with the patient. In a systole, there is no electrical activity, and because there's no electrical activity, there's no mechanical activity. And in VFib, there's too much electrical activity, and the heart can't process it. So instead of contracting and squeezing, it just shakes. Okay. And then
So using a defibrillator,
Mhm.
when the pulse is working, when the electricity is working, won't help, right?
No, because when you use the AED, you actually temporarily shut off the pacemaker. So if you were to, if we were to shock you right now, there's a good chance that we could actually stop your heart, right? And it may not start up again. So that's why we never shock somebody whose the electrical part is working. We shock somebody in ventricular fibrillation where the electrical part is out of control to reset it so that it starts up normally again. Okay, in communicating the fact of a patient's death to the family, this is another state exam question. It's appropriate for EMS providers to say any of the following except. So the one they said that we should not say is he's gone to a better place. So in other words, we're trying to speak with them, and they may not think, the fact that the patient's dead means that he went to a better place. So saying that to them may not help them. But saying to them it's all right to be angry, we can give you some time alone, we did everything we could to help, those are acceptable things. And we're basically trying to help them what they call the grieving process. When somebody grieves, it's how they deal with death of a loved one. Okay, so let's take 2 seconds. Does anybody have any questions on anything we went over right now before we knock out the last part of the quiz and start the class?
What's the reason you mentioned that you have to start CPR after a shock?
So,
You mentioned 2 reasons.
so let's think for a second. The AED is designed not for us to use. The AED is designed for somebody with no medical training to use, right? So they're assuming that the person using the AED has no medical training, and they may or may not know how to check a pulse. Okay. So when you shock somebody who's in VFib, so if the machine tells you to shock, it's absolute that the patient was in VFib. There's no doubt because the machine doesn't make a mistake. Okay, so if the machine told you to shock, you knew the patient was dead and they were in VFib. Now, after you shock them, there's a couple of things that could happen, right? The defibrillation could put them into a systole, which is death, right? No activity, so they need CPR to keep their heart perfused in the hopes that it'll start up again. The AED could have reset the VFib and put them into a normal rhythm, but the blood flow was not enough to wake them up yet. So they still need CPR, right? Because you want to get more blood flow to wake them up. Okay. Or the last thing is they're still in VFib. The shock did not work. So now for 2 minutes, we're going to pump some blood around, keep their organs perfused, get their hearts perfused with some more blood, and then we're going to shock them again. So that's the reasons why they've said, that don't even bother checking for a pulse. If the patient doesn't wake up, just go ahead and do CPR. Okay. And that's what the machine will tell you to do. Okay, so 26, one family member of a patient who's apparently dead cries out he's not dead and pleads with the EMS provider to start CPR on the patient. Which type of grieving behavior is this person displaying? So again, this is another, page or 2 in the book where they talk about, they call the stages of dying or the stages of grieving, okay? And when people either find out they have a terminal illness or when people, have a loved one that died, they supposedly go through these different stages, okay? So one of the earliest stages is called denial, which means that, God forbid you were told you have 6 months to live. The first stage would be, no, that can't be right. I can't be dying. right? The next stage would be, okay, fine, maybe I'm going to die, but I have to marry off my kids, pay off my mortgage, you know, and I have to do things before I can die. That's called bargaining, okay? Then the next stage is depression, which everybody knows, right? We get depressed because we're going to die. And the last stage, which a lot of people never reach, is acceptance, which is you accept the fact, you know, that you're going to die. Okay, so this is again another question always on the state exam. It's always worded the same way. You know, hopefully it'll be the same thing. But this is, you know, the stage that we tend to see in cardiac, and you know, when somebody's in cardiac arrest. In other words, we'll say to the family member, you know, we have to do CPR. Your family member's in cardiac arrest. No, he's not. And a lot of times they think they're breathing because they see us ventilating the patient with the bag valve mask, and they see their chest moving and they think they're breathing. And a lot of times we'll actually have to say, look, we're going to stop ventilating, and you see they're not breathing, you know, we're breathing for them. Just so they kind of get the idea that this is a serious situation and there's a good chance that the patient is not going to survive. Okay. 27, when upon arriving at an EMS call, you suddenly realize you will be late for work. The patient is unstable and no other crew members or EMTs. In this situation, transferring the care of a patient to the other crew members, who obviously are not EMTs, in order to leave for work promptly would be considered. Okay, so that we talked about being called abandonment of the patient. So there's two times there's abandonment. There's this situation where you start care and you have nobody that's at least of your level of training or higher to turn it over to, okay? Or that you take the patient all the way to the hospital and you do not give a verbal and written report to the hospital so they know what you've done so they can continue caring for the patient, okay? And then I think some of you brought up, like, how can the paramedics then turn a patient over to BLS? In other words, paramedics are on the call, the patient has a broken ankle, you know, how can they say, okay, you know, the EMTs could take it in, or the patient has a stomach ache, how can the EMTs take it in? Because they're a lower level of care. So it's a very risky thing for a paramedic to turn a patient care over, you know, but the rule basically is as long as the EMT is able to provide the care that the patient needs. So the patient has a broken ankle, the EMT is trained to splint an ankle and manage a patient with a broken ankle to the hospital, then it's acceptable. But like, let's say the paramedics turn over somebody with a stomach ache to a patient, and it turns out that that patient's really having a heart attack and not a stomach problem, or the patient's bleeding internally, and you know the patient dies en route to the hospital, then they would probably be in big trouble. So it's always a very risky situation to turn care over to somebody with less training than you have. Okay, 28. So a 12-year-old child with a badly broken leg is implied consent, right? Implied consent is somebody under the age of 18, somebody who's unconscious, somebody who has a altered mental status because of drugs or alcohol, somebody who has mental retardation, somebody who cannot make decisions for themselves, right? So 12-year-old is under the age of 18, so they have implied consent. A conscious alert 52-year-old patient with chest pain would be called express consent because they can understand. Okay, an unconscious patient is implied consent because they cannot give consent because they're unconscious. A severely autistic 35-year-old male with no parent or guardian is implied consent. Okay, autism is a problem where patients may have problems with understanding. Okay, and a 21-year-old female patient who is having a baby would be, again, she's over the age of 18 and it's express consent. And she actually has the right to make decisions for herself and for her unborn baby.
A question.
Yes.
And the 12-year-old child with a badly broken leg, you don't have to wait for the parents to give you the consent because it's not life-threatening?
Well, how do you know? That's why I put badly broken leg. So in other words, let's say that you delay care and now the child for the rest of their life has a limp and doesn't walk right. Okay, so, you know, if that child had gotten to the hospital right away and it was managed right away, then maybe they wouldn't have that problem. So, yeah, it's always going to be implied consent. Okay, match the legal term with the situation. A patient who's treated incorrectly by an EMT leading to the patient suffering further injury would be gross negligence. Okay, an EMT fails to give a verbal report or leave a written report in the emergency department would be abandonment. Okay, let me bring it a little further down, would be abandonment. E. A legal document where the patient requests that resuscitation be withheld from them if they go into cardiac arrest, okay, was a do not resuscitate order, F. A severely intoxicated patient who is not conscious can be treated because of the principle of implied consent. I don't know where that was. Implied consent. An EMT initiates care to a patient and failed to ensure that care was continued at someone with similar or higher training. The EMT can be found guilty of abandonment. You agree to respond to calls for a set period of time. You have a duty to act, right, because you've agreed to respond. The skills and procedures that an EMT is allowed to perform is called scope of practice. Okay, that's what you're allowed to do. And providing care and treatment to a patient that would be similar to the care that would be provided by another EMT with same or similar training. So this is kind of a legal thing, and that's called the standard of care. So you get sued, and they're trying to say the care you rendered wasn't good. How do they judge, you know, what's good and not good? So they basically say, you know, they try to convince the jury that your care was not what the other EMT who went to the same training you had and has the same amount of experience would have done. Okay. The airway structure where gas exchange takes place is called the alveoli, right? That's the little bag-like structures or room-like structures. They look like a bag of grapes, okay? The nasopharynx, so pharynx is the throat. There's 3 divisions to it. The naso is the one behind the nose. The oro is the one behind the mouth. And the laryngopharynx is the one right above your epiglottis, the back of your throat. Okay, so where you think the throat is actually the laryngopharynx, right? Nobody thinks the throat's behind the nose. Okay, maybe they think it's behind the mouth, but the throat that everybody kind of thinks of is the part that's a little further down called the laryngopharynx. The trachea is the start of your airway, right? And on top of the trachea is what we call the glottis, which is the structure that sits right on top of it. And the trachea is a small tube about 4 or 5 inches long, okay, that goes from the back of your throat, okay, towards your lungs. And the bronchi are the terms for the first big tubes, air tubes that come off the trachea, right? The airway structure protects the airway by preventing food and liquids from entering the trachea is called your epiglottis. So epi means above. So your glottis is the top of your trachea, okay, the windpipe. So epiglottis is that leaf-like structure, that flap-like structure that sits on top of your glottis that when you swallow, it closes the opening to the glottis, to the trachea, so that so that food will only go to your esophagus, to your food pipe, okay? And again, the oropharynx is the term for your throat behind your mouth. Okay, match the options below. An imaginary line drawn through the middle of the body, dividing the body into 2 equal right and left parts is called the midline. So that's D. Movement towards the midline is called medial. Okay, and away would be called lateral. Okay, so something going towards the center of your body is medial, something going out towards your sides is lateral. Pulse located in the wrist can be referred to as a distal pulse site because it's further away from the center of your body. And then a pulse closer to your body would be called proximal, right? So the pulse in your upper arm, your brachial, would be proximal, where the pulse in your wrist, your radial pulse would be distal. Okay, movement towards the floor would be inferior. So that's this one, inferior. Oops. Okay. The front of the body is anterior. What's that? Is anterior, and the back of your body is posterior. So this is anterior, and your back would be posterior. The femur is blank when compared to the tibia. So the femur is the bone in your upper leg, and the tibia is the bone in the front of your lower leg. So the femur would be proximal because it's closer to the center of the body when compared to the tibia. And the back can also be called so your back is the back of your chest. So it's your posterior thorax, right? Because your chest goes from your front to your sides to your back. So your back can also be referred to as your posterior thorax. Okay, Jay.
Question number 6.
Okay.
The femur.
The femur.
Why is the answer not superior?
What's that?
Why is that not the answer superior?
I can't hear you. I hear why is the answer not what?
Superior.
Superior? Okay,
yes.
so I could understand you're thinking someone's standing up, right? You would say if somebody was standing up, it would be superior. But when they talk about superior, they're more or less saying like the parts, they're parts of the body, like I'm just trying to think. So if you were saying this part of my arm, right? The top of my arm would be my superior part of my arm. The bottom part of my arm would be the inferior part of my arm. And the other thing is when they're saying when compared to the tibia. So usually when they talk about comparison, it's proximal and distal. So that's, I don't know if I answered it well, but that's kind of why. But I mean, that's actually, I'm pretty impressed because that's really thinking. So I didn't even think of that. So that's good.
I know, I think a good way to explain it is if you imagine the picture of the body standing vertical.
Okay, vertical is straight up and down. Go ahead.
I'm saying a good way to explain it might be that when you look at the picture is you imagine that the person is standing vertical.
Okay, I see what you're saying. So then the leg would not, that part of the leg would not be superior, it would be anterior if you were picturing it that way. So I understand what you're saying. Okay, so 33, the medical term for a nosebleed is A. So again, this is on every state exam and it's called epistaxis, okay? And the reason I start saying this very, very early was one of the first classes I did in New Square was a certified first responder class, not an EMT class. And in a certified first responder textbook, they didn't have this word, they just said nosebleed. So I said to the guys, oh, they're not gonna ask you ever the medical term, you know, they're just gonna ask you nosebleed, but just I'll mention it, it's called epistaxis, and I never said it again. So we're at the state exam, you know, 3 months into taking the class, we're in the state exam, and the third question in the test is this question. And they're all talking in Yiddish amongst themselves, trying to figure out what it is. And I'm like, why is it, you know, what are they all talking about? So I said to the proctor, you know, and I'm not supposed to be able to help you, right? So I said to the proctor, do you mind if I just, you know, try to find out what's going on? So I walk over and the guy points, one of the students points in his test booklet, and this was the question, you know? So now I'm very careful to always mention, right, that the medical term for nosebleed is an epistaxis. An epidural is something your wife may have had at some point when she was giving a baby. So it's basically an injection into part of the spine so that they numb the pain. And the epiglottis, right? Everything's above, right? Or, you know, so epiglottis is the flap-like structure that protects the trachea from food or water going into it, okay? Okay, so 1, was it helpful to take the quiz? And 2, was it helpful to review? Yes, no?
Both.
Very much.
Okay.
Great. Thank you.
Okay. And like I said, some of you are.
Thank you, Mr. Frank.
Some of you are calling and texting and asking questions on a regular basis. And some of you I never hear from. So I'm assuming that those of you that I never hear from you are already experts in everything and they don't need help. But if that's not the case, then you're not bothering me. You can ask any of the students. I will get back to you. I will get back to you and answer your questions. So, you know, just feel free to ask if there's something you don't understand. And I'll just tell you the one thing that doesn't seem to be working too well is a lot of people, not a lot of people, but some people are basically dictating into WhatsApp a series of questions. And my hearing's not great and I don't have a lot of time. So it's hard for me to listen to every single one of those questions. So I'd much rather either you do one question at a time or you actually just write out the question so that I can read it and just answer back to you. And did everybody get my little quick review of everything we did last class on the airway? Did
Yes,
you get that?
I got it, and that was real helpful.
Okay, so I'll try to do that obviously with the heart. And like I said, if you go onto Dropbox, a lot of this stuff exists already, whether it be, you know, tapes that you could listen to or, you know, PowerPoints or whatever it is. So a lot of the stuff's down there on Dropbox. If you haven't had a chance to look around, you know, definitely look around. Those short, brief, they call them 10-minute reviews. Some of them are actually longer than 10 minutes. Those are, you know, basically taking the whole class or the whole section of the body and just reviewing it in a couple of minutes. You know, it's not a way to learn it the first time, but it's definitely a way to review. Okay, so any questions on anything before we start the heart? No questions, we're good?
I got one question.
Yes, sir.
The pacemaker, where is that attached to? I know people.
Okay, so we're going to do that. We're going to do that tonight. So let's hold off on that one, and we're going to actually review that all tonight with the heart. So the pacemaker is actually in the heart, and we'll look at pictures and stuff like that. Okay, so we talked about the respiratory, and that's obviously how we get the oxygen in and the carbon dioxide out of the body. Okay, now once we get that air, that oxygen into the bloodstream, we have to be able to circulate that blood around. So we're going to talk about the cardiovascular system. So cardio is heart, and vascular is the blood vessels. So your cardiovascular system is made up of three things: a pump, which is the heart, tubes or hoses that the blood, which is the fluid, goes through. So you have a pump, you have the fluid, which is blood, okay, and you have the tubes. The tubes are three types. There's arteries, which bring blood away from the heart. In between an artery and a vein is a capillary, and that's where the exchange of everything comes out. So that's where it leaves the bloodstream. And then you have a vein that brings it from the capillary back to the body, right? So arteries are high pressure and they're thick because they're handling blood being pumped from the heart. Capillaries are very small, thin, and they basically let that fluid, trickle through the capillaries and kind of leak into the cells. And then the veins pick up that used up fluid and bring it back to the heart to get cleaned up, back to your kidneys, back to everywhere to get cleaned up. And then they start the journey all over again. And the blood has three components. So the fluid portion of blood, and don't worry, we're going to go over this 10 times. The fluid portion of blood is called plasma. And that's basically like slightly salty water. Okay, it's actually clearish to a slight little yellow tint. Okay, that's the plasma. And then inside the plasma, there's red blood cells, which gives the blood, when exposed to oxygen, it's a red color. Okay, and in the red blood cell, there's a protein called hemoglobin that the oxygen actually gets onto to be transported. So when when you found out your wife was a little anemic and she was weak and tired, okay, the iron is part of the molecule of hemoglobin that carries the oxygen. So if she didn't have enough iron, okay, she didn't have enough hemoglobin, and that's why she was weak and tired. Okay, there's also white blood cells in blood, which help with controlling infection. And then there's platelets, which help with bleeding control and making like scabs and stopping bleeding. Okay, so the blood has multiple components too. So now we're going to start with the heart. So we know the heart has 4 chambers. We talked about that already. The heart itself sits in a very tough sac. Okay, so here the shiny part is what's called the pericardial sac. Peri means around, and cardial obviously means heart. So pericardial sac means the sac around the heart. Okay, here they cut away part of the sac so we could see the heart inside of it. And the heart will have fat on the outside of it. That's this yellow stuff. And this is the yellow stuff on the inside of it. It's not great to have a lot of fat on your heart, but again, with crappy food that we eat and lack of exercise, we tend to get a lot of fat on it. So, if we were looking at a young, healthy heart or a heart of an athletic person, we wouldn't see all that yellow fat around it like we see on this person over here. The other thing I would assume is that this person died of a heart attack, because you see this darkened area over here. That's very usual a sign of a heart attack. That area was deprived of oxygenated blood because the artery servicing that area was blocked, and it died. So probably this is why we're looking at this patient's heart, is that they had an autopsy and they were dead, and they found out this is the area of what they call the infarction or the heart attack. Okay, and you can see some blood vessels coming off, right? This is probably part of the aorta. Off your aorta comes 3 big blood vessels. We'll see in a second. And that's basically it. Now, we're going to talk, when we talk about emergencies, there are problems that have fluid. So there's a tiny little bit of fluid between the wall, the inside wall of the sac, and the heart itself. Just acts like a lubricant, like oil acts as a lubricant for the engine of your car. Because remember, the heart inside that sac is squeezing. So if there wasn't a little bit of lubricant or oil or fluid between it, the heart would be rubbing and it would be painful. Okay, so you may have heard somebody, or even yourself, somebody may have had a disease or an illness called pericarditis. Okay, so pericarditis is where the fluid gets infected or the fluid dries up, and it's very, very painful, okay, inside the heart. And every time the heart contracts, the person has chest pain. Or there's people that have a different thing called a pericardial effusion, where extra fluid builds up in the sac, right? So there's a little bit of fluid that's supposed to be there, more fluid builds up, and it actually starts to strangle or squeeze the heart so that it can't fully expand to fill with blood, and that's a true emergency. Okay, so any questions on the sac? And its purpose is obviously to protect the heart. And, you know, again, we're never going to know exactly what's going on, but just in case you ever hear, you know, somebody explaining to you what happened to this patient.
Do we have to know and remember all these words about the heart infections and?
No. Well, when we get to, let's put it this way: do you have to remember for the state exam? I've never seen the term pericarditis or pericardial effusion on a New York State EMT exam. But, you know, right now, this is all crazy, you know, stuff for you. But a year from now, you know, this will be stuff that people will talk about, and I mean, you may remember, you may not remember it. I find typically that people graduating from EMT class know more than an EMT that's been an EMT for 3 to 5 years. Because that EMT, 3 to 5 years, has forgotten so much. And you got to remember, a lot of this stuff that we do as EMTs is nonsense, especially in the Jewish world. You know, you're going to get calls to take ticks out of people. You're going to get calls, you know, people have this and people have that. I mean, they, unfortunately, in the Jewish world, they use Hatzola, you know, as a, you know, a taxi cab, as an urgent care, you know, and all this kind of stuff. So what happens is a lot of the EMTs, they get kind of burnt out because, you know, a lot of the stuff they're doing is nonsense. I mean, yes, once in a while there's emergencies, but most of the stuff is nonsense. And, you know, the paramedics are kind of reserved for the more serious calls. So, you know, are you gonna, you know, let's put it this way: if you had a patient with pericarditis, you can be guaranteed there's gonna be a paramedic on the call. The other thing, unfortunately, you know, in the Hatzola world, you know, more, I think, the Muncie than the Hasidish ones, is that the paramedics tend to talk down to the EMTs and don't value their opinions as much as I see it in the more, you know, the more Hasidish Hatzolas and stuff like that. So, you know, and I probably things are getting better, you know. Okay, but yes, you don't have to know pericarditis or pericardial effusion, but you should know the pericardial sac is the sac that surrounds and protects the heart. Okay, so we said there's 4 chambers. Okay, now the thing that's going to make you crazy is the atrias and atriums are the same thing. Okay, so atria is singular, atriums is plural. Again, I don't know how that translates into Yiddish, but atria means 1 and atriums mean 2. So you have 2 atria, 2 top chambers. Okay, and I labeled them and drew them different ways here. Okay, and you have 2 ventricles. The atriums only have to pump down to the ventricles. The ventricles, the right ventricle pumps to the lungs. So off the, oops, I labeled this wrong. This should be, hold on for a second. I didn't see that.
That should be right.
Yep. It's good. I can still pick up on stuff. Okay. So the right ventricle pumps out into, now this is an interesting thing. I said that all ventricles pump blood away from the heart. I'm sorry, all arteries pump blood away from the heart, and they're typically, because their arteries are high in oxygen, right? Because they're bringing the blood from the heart to the cells of the body. The right ventricle, this is taking the blood that was used up, okay, and bringing it to the lung. So in your right atrium, there's 2 big veins that bring blood in. There's the superior and inferior vena cava. They bring blood, the superior vena cava, remember superior goes towards the head, empties the head, the neck, and the upper part of the chest into the right atrium. And you can't see it drawn very well here, but the inferior vena cava, actually you can see it over here. So here's the superior vena cava, here's the inferior vena cava. They're bringing blood into the right atrium. Those are both the largest veins of the body. And again, because they're veins, they're bringing blood that is low on oxygen to the right side of the heart. They're going through a valve. You see over here, it's called the tricuspid valve, okay, into the right ventricle. Now, they're not going to ask you the different names of the valves, but they may ask you what's the purpose of valves. So everybody who's a plumber knows the purpose of a valve is to only let fluid go in one direction, right? So
Check
a valve, what's that?
Check valve.
Yep. So a valve only lets it go in one direction. So the purpose of the valves between the heart, okay, and between the chambers of the heart is to only let blood go in one direction. So from the right atrium, it's going to let it go into the right ventricle, okay? And now both your atriums contract at the same time. So, and again, this is when you feel a pulse in somebody's wrist, you're actually not feeling the atriums, you're only feeling the ventricles, because the atriums only pump blood to the ventricles. So you can't feel it. In fact, when you're feeling a pulse, you're only feeling the left ventricle pump blood out into the big artery, the aorta, and you're feeling it, that blood traveling all the way to your wrist or your neck, right? So what happens is, for blood to pump through the heart, is that there's going to be these two veins bringing it into the right atrium, okay? And the pulmonary veins bringing it into the left atrium back from the lungs, and I'll explain in a second. So you have 4 pulmonary veins, you see them here and here, coming into the left atrium. You have 2 veins coming into the right atrium, the superior and inferior vena cava. Once the atriums are both filled to a certain point, and the heart knows they're filled to a certain point by the pressure or stretching on them, what will happen is that these 2 valves between the atriums and the ventricles will open, and blood will flow by gravity, just by flowing, right, from being higher to lower into the ventricles. And then pretty much about 60 to 75% of the blood that comes from the atrium to the ventricles is just gravity. And then what will happen is both atriums will give a little contraction, a little squeeze, and push the rest of the blood down into the ventricles. Then these valves between the atriums and the ventricles will close, and the valves between the ventricles and the blood vessels they pump into will open. So the right ventricle pumps into the pulmonary artery, and if you notice, the pulmonary artery splits into 2 arteries. So that's because there's 2 lungs, right? So it splits up into a right pulmonary artery and a left pulmonary artery to go to the right lung and the left lung, okay? And there's a valve at the entrance of it called the pulmonary valve, and the left ventricle pumps into the aorta, and there's an aortic valve. So again, now that we got blood from the atriums to the ventricles, now the ventricles are full and they're going to pump where they need to pump to. So what has to happen is that the valves between the atriums have to close, so that when the ventricles pump, blood doesn't go backwards, and the valves into the blood vessels have to open so they can pump blood into the blood vessels. So again, now we're ready for the 2 ventricles to pump. The valves between the atriums and the ventricles close so blood doesn't go backwards. The valves into the blood vessels, the right ventricle pumps into the pulmonary artery, and the left ventricle pumps into the aorta. Those valves have to open, okay? Now they'll squeeze and pump blood, and the right side will pump to the lungs for gas exchange. The left side will pump to the rest of the body, okay? So the right side pumps to the lung to get oxygen and get rid of carbon dioxide. The lung then sends blood back to the left side by the 4 pulmonary veins. That blood is now high in oxygen, and it goes from the left atrium to the left ventricle, and then it goes into the aorta and pumps out. But again, both atriums contract at the same time, and then both ventricles pump at the same time. The atriums both pump down to the ventricles. The right ventricle pumps to the pulmonary artery, which brings blood to the heart. The left ventricle pumps to the aorta, which brings blood to the rest of the body. Now, here's the interesting thing. On the test, they're going to say to you, is an artery high in oxygen or low in oxygen? And you're always going to answer it's high in oxygen, with the exception of one artery, which is the pulmonary artery. The reason it's called an artery is it's pumping away from the heart, right? It's going from the right ventricle to the lungs, so it has to be called an artery. The reason it's low in oxygen is it's taking the deoxygenated, the blood that was used up from the right side of the body, right, from the whole body into the right side of the heart, and pumping it to the lungs to get oxygen. So guaranteed test question, what's the only artery that's low in oxygen? It would be the pulmonary artery. Or sometimes they'll say what's different about the pulmonary artery, and it's the only artery that has blood in it that's low in oxygen. Now, the pulmonary vein, technically every vein is low in oxygen, but since the pulmonary vein, okay, is coming back from the lungs, it's called a vein because it's going back to the heart, just like the vena cavas, which were veins, were called a vein. Okay, so it's a vein because it's going back to the heart. It's the only vein that's high in oxygen because it's bringing blood back from the lungs that just got fresh oxygen. So that's the only vein, okay? So we'll talk about it, guaranteed to be a quiz question. The only artery that's low in oxygen is the pulmonary artery. The only vein that's the only vein that's high in oxygen is the pulmonary vein. So if they give you a thing where it says anything about oxygen and blood vessels, and they say, when is it different? It's got to be pulmonary. And then you just have to figure out if they're saying low in oxygen or high in oxygen. Okay.
The question is,
Whoops, I muted you. Say it again. The one person who's just saying the question is. Okay, when you can figure out.
I just see something just to clarify if I understand it right.
Mm-hmm.
That when the heart is recoiled, when it comes back up, then the valve and the atrium opens up, and when the heart is compressed, then the valve and the ventricle is opening up.
So you're asking what's happening when the heart is contracting and relaxing?
Yes, because we always learn that by doing the chest compressions, you have to leave the heart to recoil fully in order the ventricle to get full with blood again.
Right. So that's when the heart is not beating itself. So the way it works when the heart is beating itself is that blood flows passively. Just remember, again, this is something that plumbers understand. If you have a pump, right, this is the heart, and it's pumping blood throughout the whole body. So where the pump first starts to pump blood is where the pressure will be the highest. And at the very end, where the blood is making it back into the pump, it'll be the lowest. So the blood pressure is always the highest in the aorta because that's right off the left ventricle. And it's always the lowest, okay, in the superior and inferior vena cava because that's the last blood vessels right before it gets back into the right side of the heart, okay? So what happens now to move blood is that the heart contracts. For the chambers to refill with blood, then yes, they have to relax. So when the right atriums contract, they push the blood out. When they relax, they bring blood back in.
So technically, when you do CPR, the ventricle doesn't fill up as it's supposed to with the full amount.
Yep, that's why they say perfectly done CPR is only 25% as effective as a beating heart. Perfectly done.
how does the vein have high oxygen when it's getting from the artery low oxygen?
No, so the reason the pulmonary veins are high in oxygen is they're coming back from the lungs. Remember, the right side.
But the lungs have a low oxygen.
What's that?
But the lungs have a low oxygen, you said.
No, the lungs have high oxygen. So the lungs are where we bring oxygen in, right? We breathe oxygen in from our trachea into our lungs, and we're getting that oxygen then from our lungs, from the alveoli into the blood vessels, okay? Okay, so now I said that the cardiovascular system is made up of the heart, that's the pump, the blood, that's the fluid, and the blood vessels that are the tubes, okay? So why do we have a cardiovascular system? So it has to transport gases, which is the oxygen, the carbon dioxide, nutrients, which are good things, the food for the body, right, which is our sugar and our vitamins and our minerals and everything like that, okay? It has to remove waste products, the things that we don't need from our body. So again, the blood itself doesn't remove the waste products. They pump it to places that have to remove it. So in other words, they pump it to your lungs to get rid of carbon dioxide. They pump it to your kidneys so you urinate it out. They pump it to your liver because your liver actually cleans your blood. So, so the blood basically is what we call a transport mechanism, right? So the purpose of the blood is to transport things around to different parts of the body so they could be used. Hormones are just different substances in our body that there are chemicals that play a role in coordinating different things. So we don't really get into hormones too much on an EMT level. So again, they're going to ask you on the test the flow of blood through the heart. So they always have to start somewhere. So blood starts coming into the right atrium from the inferior and the superior vena cava, which are the two big veins. So it comes into the right atrium, goes through a valve, okay, into the right ventricle, goes through another valve into the pulmonary artery. Remember, the pulmonary artery splits, okay, into two arteries that's then split into more and more arteries to go out throughout the lungs, okay? That's where it gets rid of the carbon dioxide. Again, since this was blood that was used up in the whole body, it's high in carbon dioxide, low in oxygen. It's going to the lungs to get rid of the carbon dioxide and pick up more oxygen. Once that happens, it comes back to the left side of the heart because the right side pumps to the lungs. The left side gets blood back from the lungs and pumps it to the body. So it comes back, okay, into the lungs by the pulmonary veins. Okay, so you see the pulmonary veins coming in and in, right? This is looking like it's going into the right atrium, but it's actually going into the right ventricle. So they come into the right ventricle, they go through a one-way valve into the right ventricle, and then the right ventricle pumps
Left,
up into
the left
aorta.
ventricle.
I'm sorry, you're right. Left ventricle pumps up into the aorta. Whoops. Okay. So the aorta comes up. There's 3 blood vessels that bring blood up to your brain and your neck and your arms. And then it comes down. This is called the arch of the aorta. It comes down behind the heart and continues to travel down your aorta to about the level of your belly button. And that whole way down, there's other arteries that branch off of it and bring blood to your whole body. When it gets down to about your belly button or your umbilicus, it splits into 2 arteries called your iliacs that then split into other arteries that bring blood down to your legs. Okay, so that's basically how blood flows through the body. And again, this is just another picture showing you through all these little lines and strings are how the heart actually opens and closes the valves. So there's a series of cords inside your heart that pull on the valves between the different chambers of the heart and the blood vessels in the heart and open and close them as they need to be opened and closed. Okay, and it all works perfectly, you know, for hopefully many years until we, you know,
the blood that comes back from the lower part, from
the lower part of the body.
that goes down, yes. How
Okay.
does that come back? It just comes back from the new pressure, from new blood with
That's
the
that's
oxygen going
a
down?
really good question. So it comes back from, remember, when you have a pump built into a closed system, right? So you have your furnace in your house, okay? So your furnace, your boiler in your house is pumping water through a whole series of pipes. So it's got to go from your basement, okay, up to your living room and then back down to your basement. So it's, in other words, the pressure is higher when it's pumping up, okay, but there's still flow after it travels through the radiators in your living room. There's still flow back down to the boiler in your basement. It's the same thing with your heart. But there's one other thing that's a good question, is that most of the blood we move from our lower extremities back up through our diaphragm, through that muscle of breathing, right? Back up to our heart and our chest. A lot of it happens by walking. When you walk, okay, the muscles in your legs are moving and pressing on those blood vessels and pushing that blood up, which is why you've probably all heard the term varicose veins, and you've seen people who have these big bulgy veins on their legs. They're all distended and ugly looking. So somebody like a chef, a cook, somebody who stands on their feet all day long, because they're not walking and because there's more blood now obviously in their lower legs, if this goes on for years and years and years, those veins get stretched and they never go back to normal. It also happens after women are pregnant because the pressure of the baby on their belly doesn't let the blood flow back up. So yes, some blood flows just because the heart is pumping and there's just some flow no matter where it is in the body, right? Blood can't sit still, so there's always going to be some flow. But we really move most of our blood, okay, by walking. Now, somebody's going to say, well, what happens when you're sleeping? So when you're sleeping and you're laying flat, it's easy for blood to pump, right? There's no gravity, there's no pumping upwards. And the other thing is that when you're laying flat, your blood vessels relax and it's easier for the blood to flow through, okay? That's why if you've ever been sound asleep and your kid started screaming for you and you jump up to go see what's going on, you may feel dizzy, because when you're sleeping and all relaxed, your blood pressure is the lowest and your blood vessels are totally dilated, open. Dilation means opened, and your blood pressure is very low. If you jump up suddenly, you may not be getting enough blood to your head for that brief second until the body corrects itself, and sometimes people faint and hurt their heads. Okay, so now the pacemaker, right? So the cardiac conduction system is the fancy way of saying that the heart has a built-in pacemaker system. Now, a pacemaker basically is like a brain for the heart. So your brain, you know, is in your head, but the heart has its own brain or computer that sends out the signals that the heart needs for itself to be able to contract. Now, do me a favor, and it's 9:11, so when I finish this little section, just tell me to take a break. Okay, so when I finish this cardiac conduction system. Okay, so what you have is a series of nerves. Okay, nerves are basically wires, okay, throughout the heart that are connected to little sites that are like little computers, okay? So the first one and the most important one is called the SA node, okay? So it stands for the atrium, sinoatrial node. It's high up in the right atrium. Okay, it's this little yellow blob over here. And you see it has wires that are going off of it, and the wires actually go over, if you can make it out, go over to the left atrium. So this is what they call your dominant pacemaker. It means your main pacemaker, and it's set to beat 60 to 80 times per minute, which is why our normal pulse is 60 to 80 beats per minute, okay? And it sends out an impulse 1 time a second. So if your pulse is 60, once every second, okay? And what it does is it makes both atriums contract, okay? Then the impulse comes down to this little area over here called the atrioventricular node, okay? It holds it for a second, because I said that the way blood comes from the atrium to the ventricles is that the valves open and gravity spills blood, and then it holds it for a second to give your atriums a second to contract and push the rest of the blood down. Then it makes both ventricles contract and push, the right side pushes into the pulmonary artery, the left side pumps up into the aorta to go to the rest of the body. So this is your cardiac conduction system. They don't
This happens like in every second. You have the top.
Yep.
The one that's on the top that gives you a beat.
Yep.
That's for a second. Then when does the other one take over?
It happens instantaneously. It happens instantaneously. You don't even notice the difference. In other words, it happens. So if a second, okay, is a period of time, like we have 60 seconds in a minute, okay, it takes about a millisecond or about 100th of a second for this whole thing to happen. So what happens?
The first one starts, the second one takes over, and that's
boom, one right after the other, exactly. So if the whole thing happens in a second, that your atriums and your ventricles contract, in other words, the whole thing's happening, the whole heart is working in 1 second, the impulse, from the time the impulse comes out of the SA node to the time your ventricles squeeze, you know, is 1 second. That's telling you how fast this is all going. So it's like, it's the same thing like how, you know, you send a signal through one computer to another computer, right? You're in your
Now, when you hear an irregular heartbeat, is it because one is they're giving different signals? It's taking more than a second.
Because the normal pacemaker site, the SA node, okay, is not in control anymore. So it's an interesting thing about the heart, okay, and we're getting a little off topic, so I'll only spend a second on it, but when we get to cardiac emergency, we're going to talk about it much more. But that rhythm, atrial fibrillation, right, we said was the upper parts of the heart squeezing, and the lower parts were ventricular fibrillation. We said the upper parts, the people could be alive. So in atrial fibrillation, what happens is this SA node, because of old age and disease, doesn't work anymore. So the body always has what they call redundant systems. Redundant systems means that one system fails, another system takes over so that you stay alive. So the way the heart basically works is that if this gets knocked out, one of two things could happen. It'll depend on the lower one, which is set to beat slower, 40 to 60 beats per minute, because the heart always listens to whoever beats the fastest. Or the actual atriums, one little part of the atrium, it doesn't matter where it is, can actually decide to start becoming its own pacemaker and start sending out impulses. So when somebody has atrial fibrillation, I said in ventricular fibrillation, there were too many signals coming out. In atrial fibrillation, there's also too many signals coming out, but they're starting up here, where in ventricular, they're starting down here. So when somebody has an irregular heartbeat, all it's telling you is that the normal pacemaker site is not controlling the heart the way it should, and some other pacemaker site is taken over. We don't really care as EMTs where it is or what it's called, but it's a good question, which is that if the normal cardiac conduction system, the normal pacemaker was working properly, then you're right, the heart should be, the interval between heartbeats, the time between each heartbeat should be the same. So you should feel boom, 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 boom. If it's jumping around where you feel boom, 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 then nothing, then boom, 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 something like that, where it's very irregular, it's telling you that the normal cardiac conduction system is not working properly. And that's something that the patient doesn't know they have a history of it. That's something that needs to be evaluated in the hospital. Okay, so any questions on the pacemaker? Okay, so it is, it's 9:16. Let's take a break till 9:30. Okay, stretch your legs, use the bathroom, get some water and stuff like that, and then we'll come back and finish the heart, okay? I'll probably come back a little quicker if anybody has any questions they want to ask, okay? So go take a break. Okay, what's your question?
You wrote today on the text that you sent out, there's 500 million alveoli in your lungs.
Mm-hmm.
Correct?
Yep.
It's like the 500 million like Biden, or it's real 500 million?
It's very hard to picture. I listen. And I mean, think about how many miles of tubes you have in your lungs, right? That's why it's truly a miracle, right? I mean,
Wow, I was reading it a few times to see, is it really 500 million or he's mixing up with the voting or something?
No, 500 million. You can go on the internet, 500 million.
I believe you. You're more clear than the internet. Wow.
So
what is 500 million alveoli doing? It has so much to handle.
Yeah. Well, first of all, I have to be honest with you. I was meaning to look up. In other words, do we lose some and gain some? Like, do some die and some are made again and stuff like that? I don't know, but no. I mean that's why like think about somebody who smokes, right? So eventually, right, 30, 40 years of smoking is going to destroy your lungs, but it takes 30 or 40 years to destroy them because you have so much extra capacity, to be able to do it. That's why people can run, some people can run 26 miles and be alive, and some of us can run a mile and die, so the lungs have a lot of capacity. I mean, they have a ton of capacity, even your heart. I mean, think about it. Somebody mentioned before, the thing is that your heart is beating for, 120 years, right? And it's beating 1 time a second. I mean, if you did the math, how many gallons of, gallons and gallons of blood every day you're pumping through, your miles and miles of arteries, right? That's the same thing. Just like we have miles of bronchioles, we have miles of arteries. So it's truly a remarkable system, that keeps us here.
Yeah, sophisticated.
So. I'm just going to see if we can find any good questions to keep us occupied while we're waiting for to start class again.
By the way, you put a question on the group today, an extra quick question. What blood vessels is in close contact with the alveoli?
Yep.
Alveoli?
Hold on 1 second. Okay, so just remind me that somebody asked a question on the chat. Just let me show you one thing here. Now, what was your question you just asked?
On a question you posted today on the group, on the WhatsApp group, you asked an extra quick question.
Mm-hmm. So that was, it said, what blood vessels are in close contact with the alveoli and allow for exchange of the oxygen and carbon dioxide between the bloodstream and the alveoli? And that's
is that the
pulmonary capillaries? Yep. A lot of people answer capillaries, and you're correct. But then I asked you what specific capillaries, and they're called pulmonary capillaries because they're in the lung, right? So pulmonary is another way of saying the lung. Okay, so let's look. Can everybody see these couple of questions up here on the screen? It says pulmonary circulation. So pulmonary circulation is their way of saying lung circulation, right? So blood flow to the lung is what they're saying here. Lung circulation starts when blood is forced into the pulmonary system by contraction of which chamber of the heart? So what do you think?
Right atrium.
No, right atrium pumps to the right ventricle.
The right ventricle.
Right ventricle pumps to the pulmonary artery, good, and the pulmonary artery goes to the lungs. Okay, so now we know another state exam question. Okay, the exchange, number 17, the exchange of oxygen and nutrients from blood cells to tissue cells takes place in the, so which of those blood vessels does the exchange of oxygen and nutrients take place in?
The capillaries.
Very good, right? So now you have 3 and 4 you've never heard before because we haven't got to them, but venules are small veins and arterioles are small arteries. That's all they are, Okay. So you heard arteries, veins, and capillaries. Okay, so anatomically, so again, anatomy and physiology, anatomically, the term superior in relation to other body structures is defined as?
Toward the head.
Very good. So look at this. We could stop class tonight and you might be able to pass half the state exam. 20, a tube-like anatomic structure that carries air from the throat to the lungs is called the?
The tube-like anatomic structure that carries air from the throat to the lungs. The trachea.
Good. I see some of you smiling, so at least we're having fun tonight. Okay, all of the following are parts of the respiratory system except?
Esophagus.
Very good. The esophagus is the food pipe. Excellent. Yep. And then the last one, and then we'll go back to class. 22, the tiny sacs in the respiratory system where exchange gases are called. That exchange gases are called. Alveoli. Okay, so don't get discouraged. You guys are actually doing phenomenally well. I'm very impressed. Okay, very good. Okay.
Question. Simple section that wants to cast it.
Okay, hold on. Let's see. Okay. So those were all state exam questions. So if you could answer them that quickly, you're doing good. If you couldn't answer them that quickly, keep on reading and keep on asking questions. Okay, so we have the slide up that says circulatory system, and now we're up to the blood vessels. So we said there's three main types of blood vessels. There's arteries, which bring blood away from the heart, okay? And they tend to be high in pressure, okay? And they have high oxygen levels, with the exception of one artery that we said was the pulmonary artery, okay? And that's the only one that's low in oxygen because that's bringing blood from the right side of the heart, which is always low in oxygen because it's used up blood, to the lungs. Then we have veins, okay, which bring blood back to the heart, okay? They tend to be low in pressure, okay? And there's only one vein that's high in oxygen, which is the pulmonary vein because it's bringing blood back from the lungs where it got fresh oxygen to the left side of the heart to be pumped to the body. And between arteries and veins is a network of capillaries. And that's the most important blood vessel. Everybody thinks arteries are the most important blood vessels, but capillaries are the most important blood vessels. The most numerous, right? You have more miles of capillaries than anything else. Okay, they're tiny, they're microscopic. You need a microscope to see them. They're very small, just like the small bronchioles are the size of your hairs. Okay, whoops, some people got kicked out. Okay, the capillaries are also very small. Okay, but the reason that capillaries are so important is because that is where whatever is in the blood that needs to get into the cells, that's where it's going to transport and be able to get out of the blood cells, out of the blood vessels into the cells of the body, right? So capillaries are very important. And then the test you saw, what's that?
You once mentioned that the capillaries, usually when someone gets a cut, those are the ones that usually get damaged. Do they get replaced? They grow back?
They can repair themselves, sure. I mean, you've all bled, right? And what happens is the body uses part of the blood called platelets that we just talked about a second ago, right? The blood has plasma, which is the fluid portion, red blood cells, white blood cells, and platelets. Platelets basically make a plug in the wounded blood vessel and stop the bleeding, and then yes, it repairs itself. Just like when you have a broken leg, your bone can repair itself. Pretty much every part of your body, with the exception of brain, can repair itself. Brain doesn't do a good job in repairing itself, but pretty much everything else does a good job in repairing itself. Okay, so just because we saw in the exam a second ago when we were just doing a little review before we started up class again, small arteries are called arterioles and small veins are called venules, right? So I'll make sure to add that, into the slide going forward. It might even be here as we go on. I'll have to look. Okay. Okay, so this is just showing you what the different blood vessels look like as far as size goes, okay? So an artery, because it's handling high pressure blood, is much thicker and stronger. Now, all blood vessels have muscle in them. They're a form of smooth muscle. If you remember from one of your earlier classes, we said there's three types of muscle. There's smooth muscle, there's skeletal muscle, and there's cardiac muscle. Smooth muscle, we said, was in the bronchioles of the lungs, the blood vessels, okay, your digestive, your intestine in your stomach, okay, and also in your urinary tract, what did you urinate through? And women have smooth muscle in their uterus of their, that pushes the baby out. And then we had skeletal muscle, which is the muscle that between bones and tendons, right? That makes our muscles that make us move, our extremities.
That's voluntary.
Voluntary and involuntary.
Right. So voluntary muscle is skeletal muscle, and involuntary muscle is smooth muscle. And again, the only difference between voluntary and involuntary is that in involuntary muscle, okay, the body controls it. So that's like the things that we don't have to be awake to remember. And voluntary muscle is skeletal muscle that we think we want to move somewhere and our brain tells those muscles to move. And then we have a special muscle called cardiac muscle that's in the heart. And the thing that's special about cardiac muscle is it doesn't need the brain to tell it to contract because it has its own brain, which we call the cardiac conduction system that we just went over. Okay, and then you could see with the capillaries here that they're a 1-layer blood vessel where the other ones are 3 layers, okay? And the capillary is 1 layer because it has to be nice and thin so that whatever needs to leave the capillary is able to go through the wall of the capillary into the cells. The other thing you may or may not notice here is that veins have valves. So somebody who was a plumber talked about check valves and remember I said valves only let blood go one way. So in an artery, you don't need a valve because there's so much pumping, there's so much force, blood will only go in one direction. Even if you're upside down, blood in the artery still goes in the right direction. But remember I said it's hard for blood to get up from your legs, okay, back up to your heart. It's a slow journey and a lot of it is accomplished by muscles moving. So the vein has valves in it. So blood would be pictured going this way. In other words, this is your lower leg pumping up towards your heart. And what happens is that every couple of inches you have a valve. So the blood is able to go this way through the valve, but if you're not doing a lot of pumping, it's not able to go backwards through the valve. So that it allows blood to kind of inch its way back up towards the heart because of these check valves there every so often. And if you ever sometimes see in older people, when you look at their arms and you see their veins, through their skin, you see that it looks like every so often there's a little bump. That's a valve. And what happens is that as you get older, these valves kind of swell because of the higher pressure and they're a little more noticeable. And when people get varicose veins, what's happening is between the 2 valves, right? So say there's another valve up here, if the blood is not flowing well because they stand on their feet or, they don't move around a lot or they're pregnant, the blood vessel between the 2 valves starts to swell. So this wall of this blood vessel just gets big and floppy. And it stays that way. And again, this is not something that happens in a day. Like it could happen in a woman. Typically, it doesn't happen on the first pregnancy, but after repeated pregnancies, okay. Or it could happen on somebody who has a job where they stand on their feet all day. And if they're not moving around, now sometimes people wear pressure stockings to prevent that happening. And pressure stockings basically squeeze your legs so they don't let the blood vessels get dilated. Remember, dilated means that the blood vessels get bigger. Constricted mean the blood vessels get smaller. Okay, so just to review, arteries are high pressure vessels.
Just an interesting question.
Mm-hmm.
Not at the belong for EMTs, more for paramedics. When you start a line, an IV line, you go into the vein, you have to be careful not to go into a valve?
So what happens when you go into a valve is you can't advance the IV catheter. So a lot of times what will happen is you will try to start an IV, and as you're advancing the catheter into the vein, it'll stop going. And it means you're up against a valve. So there's 2 things you could do. One is you could connect the IV catheter to the IV fluid and open up the fluid and start letting it run through, and that may open the valve so you could snake it through. Or you just got to pull it out and start over again. So that could happen. But what happens is when you're looking for a vein, you try to get a nice, straight, clean piece of vein so that you're not, anywhere near a valve. And sometimes you can't tell. Some people, you can't see their veins, on the surface of their skin. So it's hard, but that's a good question. Okay, so arteries are high pressure vessels, right? And remember, the highest pressure would be in your aorta because that's your largest artery right off your left ventricle. They bring blood away from the heart. They're usually very high in oxygen, we said, except the pulmonary artery, okay? And when we do shock and bleeding and trauma, they'll say that bleeding from an artery is usually bright red and it spurts with each pulse, which means that if you were to cut an artery, every time the heart contracts, the blood that comes out the hole in the artery spurts. But obviously, that doesn't last forever because we only have about 6 liters of blood, right? So you know, if you keep on bleeding and nobody controls the bleeding, eventually you're going to lose your blood, you're going to die, but the bleeding is also going to stop because you have no blood left, okay? And here, so I didn't have to rewrite it, here is arterioles are the medical term for small arteries. So the way it would work is you'd have your aorta, which is your largest artery, okay? Off your aorta are other arteries, not as large, but large, right? Not as big as your aorta, because that's the biggest one. And then those arteries start to branch into smaller and smaller arteries that are called, and the smallest arteries right before they turn into capillaries are called arterioles. And then arterioles turn into capillaries. Now, it's not a one-for-one. When an arteriole goes into a capillary, you're going to see in a second, it's actually a whole network of capillaries, okay? Because it has to cover a whole area that it's supplying with blood. And then after the blood goes through the capillary, it ends up into a small vein called the venule, into a medium vein, into a bigger vein, and eventually it winds up in the superior and inferior vena cava that empty into the right atrium of the heart. And then the whole thing starts over again. Okay, so now let's talk about some important arteries. Okay, so you have coronary arteries. A lot of people confuse coronary arteries with carotid artery. Your coronary arteries, remember coronary is the heart. So your coronary arteries are the arteries on the surface of the heart, and their sole purpose is to give the heart itself the oxygen and the sugar and the nutrients it needs to stay alive. When someone has a heart attack, it's a blocked coronary artery. When you heard bypass surgery, when you heard stents, those are the coronary arteries that they're trying to fix. Okay, so they run along the surface or outside of the heart, right under the pericardial sac. We saw that tough sac that was covering the heart. So when you have bypass surgery, they actually cut open the pericardial sac, okay, to be able to access those arteries, and then they sew it back together, okay? So your coronary arteries, they start at your left ventricle, where your left ventricle meets your aorta. So your coronary arteries get the freshest, okay, most oxygenated blood to take care of the heart itself. So basically, your heart is feeding itself before it feeds any other part of the body, okay? Then off your left ventricle is the largest artery of the body, okay? It's your aorta. It goes off your left ventricle, comes up, arcs over the top of your heart, and then goes behind your heart, in front of your spine or backbone to about the level of your belly button, and then it splits. And remember, off of your aorta are all the other large arteries of your body. Your pulmonary artery is the only artery that's low in oxygen. That starts on your right ventricle, and it brings the deoxygenated blood from the right. When you say deoxygenated, it means low oxygen. The deoxygenated blood from the right side of the heart to the lungs, so it can get rid of the carbon dioxide and pick up the oxygen. Okay, your carotid arteries, you have two carotids on either side of the neck. Okay, when it says bilateral, so lateral is the side, bilateral means both sides of the neck. And we never press on both carotid arteries at the same time because we don't want to shut off 50% of the blood flow to the brain, right? And then you have femoral arteries that I'm going to show you better pictures in a second that are in your upper leg and your groin area. We don't really talk about popliteal arteries on EMT class, but they're behind your knee. And again, the test sometimes asks about posterior tibial and dorsalis pedis, which are on your feet and ankles. And I'll show you better pictures. The only reason they talk about those lower ones are because if somebody has a broken leg, sometimes we need to assess whether or not the fracture, the broken leg, has interfered with blood flow. So if you have a broken leg where your leg below the site of the fracture is cold and pale and lifeless, that's a much higher emergency than somebody has a broken leg, but their toes and their feet are pink and the blood flow is good and they're just complaining of pain, right? So one needs immediate surgery if you're not having any blood flow. The other one's just going to need a cast. So that's why they talk about those arteries. Okay, so other important arteries. So your brachial artery, okay, is on the medial side, which is the inside of your upper arm. I'll show you pictures of that, okay? Your radial artery is on the lateral side of your wrist by your thumb. That's the most common artery that we check in a conscious patient. Your carotid artery in your neck is the most common artery we check in an unconscious patient, okay? Not that we really talk about it too much in EMT class, but on the opposite of your radial, on your pinky side, so on your medial side of your lower arm is your ulnar artery. Okay, it's just a little harder to find because it's not as strong. Okay, your posterior tibial is on the inside of your ankle on your lower foot. I'll show you a better picture. And your dorsalis pedis is on the arch or top of your foot. And obviously they're on both, you have one on each side, okay? Your temporal artery is on the side of your head. So when you feel pounding, that's typically your temporal artery that you feel, okay? Axillary artery is in your armpit, okay? So the medical term for your armpit is your axillary area. So again, we never really feel that one, but just when we talk about trauma, if you ever see somebody running and they're like try to push open a glass door and they drive their arms through the glass door and they have cuts. So the cuts on their arms can be serious, but if the piece of glass goes into their armpit and severs their axillary artery, they're going to die because there's no way to get in there to stop the bleeding. And then the apical pulse is not a pulse that you actually feel. It's a pulse that you listen to over where the heart is, which is basically the center of the chest, okay, with a stethoscope. So even though it's called an apical pulse, it's not a pulse that you can feel because obviously you cannot feel through the sternum and the rib cage and the pericardial sac onto the heart itself. Although, sometimes if somebody's heart's pounding hard enough and you put your hand on their sternum, you can actually feel it. Like if you have a small baby and you put your hand on their sternum, you could actually feel their heart pounding. Okay, but when we talk about an apical pulse, it's something that we hear with a stethoscope. Okay, the coronary arteries, we said, are the arteries that run across the surface of the heart. So the red arteries, the red blood vessels are arteries, the blue blood vessels are veins. So obviously if you have a coronary artery, you also have to have a coronary vein because if arteries are bringing blood to a certain area, veins are bringing it back. So the coronary arteries supply the myocardium. So if you remember from the other class, myo means muscle, and cardium is heart. So it's the heart muscle. It's the part of the heart that actually does the pumping, which is the entire heart with the exception of the cardiac conduction system. So the coronary arteries supply the heart itself, okay, with the blood it needs to stay alive. They start at the left ventricle, right? So they get the freshest blood. And when somebody has a blocked coronary artery, that is a heart attack. And the medical term for a heart attack is myo, which is muscle, myocardial, heart muscle. Infarction means death. Okay, that's the worst part of a heart attack. We try to not let them have a true myocardial infarction. We try to get them and treat them, give them aspirin and oxygen and get them to the hospital to have other things done for them before the actual muscle dies, right? So even though we call it a myocardial infarction, our purpose is to prevent them from actually having the infarction, which is the death of the tissue, because if enough of the heart tissue dies, the patient dies. Veins, we said, are lower pressure vessels. They bring blood back to the heart. They're usually low in oxygen. So the term low oxygen is deoxygenated blood, right? Did you hear me keep on saying deoxygenated means low oxygen? And the exception, the only vein that's high in oxygen is the pulmonary vein. And that's because the pulmonary vein starts at the lung and brings blood back to the left side of the heart. So since it's coming from the lungs, it just got fresh oxygen. Veins have one-way valves because they're low pressure, so they have to make sure blood only goes in one direction. Venules are the term for small veins, just like arterioles are the term for small arteries. Okay, and bleeding from a vein is usually dark red, so it's not bright red because the oxygen level is not high, and they describe it as maroon. So maroon is kind of like a reddish purplish color, okay? And when an artery bleeds, it spurts. When a vein bleeds, it flows freely, as if like you were turning on the faucet, right? It's just free flowing of fluids. Okay, so again, most of us has never had arterial bleeding or venous bleeding. Okay, we've had capillary bleeding where it kind of just oozes up to the surface and then it flows by gravity. So in other words, it oozes to the top of your hand and then it starts to flow down towards the floor because of gravity, not because of flow of blood. Okay. Okay, so capillaries are the smallest but most numerous. So I think they say something is like 100 times more capillaries than every other blood vessel, right? So the most numerous blood vessels in the body. Microscopic means you cannot see them with your naked eye. You need a microscope. They're low pressure vessels because they take that high arterial pressure and they basically bring it down to a safe pressure so that things could get into the cells. And remember, there's not just, off of each artery, there's not just a single capillary. It's called a capillary bed, which means that it's a lot of little tiny connections that where the different nutrients can leave the blood vessels and get into the cells. Okay, after it goes through the capillary bed and it gave up what it needs to give up and got the waste products back out of the cells to bring back to the heart, it comes back into a venule, which is a small vein that then goes to a medium vein, a larger vein, all the way back to the heart, to the superior inferior vena cava. The exchange of nutrients, oxygen and glucose, okay, it takes place in the capillaries, and also the waste products that were generated by burning that sugar and burning that oxygen, okay, mainly the carbon dioxide and, you know, other waste products that we have to get rid of by the kidneys and the liver, okay, are brought back into the bloodstream to be transported to whatever organ is in charge of getting rid of the garbage out of our body, okay? It's usually high in oxygen into the capillary bed, and then obviously low in oxygen on the way out, because once it travels through the bed, the oxygen has left, right, the capillary. So, you know, if the purpose of the capillary is to give oxygen up, it's high when it gets into it, but as it's leaving, going back into the vein, it's low because it's used up the oxygen. So bleeding from a capillary is usually red in color, not as high, not as bright red as a arterial bleed, but a little brighter than a venous bleed, okay, and it's oozing in color. I'm sorry, oozing in flow. So oozing means that it's not freely flowing, it's the kind of bleeding you've mostly seen where it kind of drips up to the surface, you get like a little bubble, and then it kind of flows in one direction. Okay, I actually have a mannequin that has a mannequin is like a fake, like a CPR mannequin, like a fake person. But we have a mannequin for bleeding control where we basically put it in like a box that looks like a little bathtub, and we can put red food dye fluid into it, and then we turn on a pump, and you can mimic any type of bleeding. So we could actually practice trying to stop arterial bleeding and see how hard it is, okay? So fluid, oxygen, and carbon dioxide exchange take place through the walls of the capillaries. Okay, in the lungs, oxygen enters the blood, okay, and carbon dioxide leaves the blood. Again, the part of the blood vessel is called the capillary, okay, and at the tissue level, okay, oxygen leaves the blood and carbon dioxide enters the blood. So we have two different places, right? We have two different places we have gas exchange. We have in the lungs, where we're getting the oxygen into the bloodstream, and we're getting the carbon dioxide out of the bloodstream. But in the cells need the oxygen, so the blood is giving up the oxygen into the cells so they could use it, and it's getting rid of the carbon dioxide out of the cells because the cells don't need that because it's a waste product. So you have two different.
What is that tissue level?
I'm sorry?
What is the tissue level?
When they say tissue level, they mean the cells, like the actual parts of the body that need it to do something. You know, so it's like, remember, it's kind of hard to describe, but we are millions and billions. Like if you thought there was too many millions of alveoli, there's billions and billions of cells, okay, in the body. So we're just this little collection of all these tiny little microscope, like a cell you cannot see with a naked eye, you need a microscope. So sometimes you may have gone for a blood test and they tell you, you know, we can't tell you if you have this disease or not till somebody looks at it under a microscope because they're looking for certain blood cells, a lot of times like cancer cells and stuff like that. So these are tiny, tiny little things you cannot see, okay? But every one of those, okay, cells has the ability to generate energy. But to be able to generate energy, to make something happen, they need fuel. And the fuel is the oxygen and the sugar, okay? Okay, so this is trying to explain a capillary bed. So we said that we have large arteries that flow into smaller arteries called arterioles. So everybody can see artery and an arteriole, right? And then at the end of every arteriole, there's a bed of capillaries. So this little area in here is this bed of these tiny little blood vessels. This is throughout every square inch of your body, right? So every square inch of your body, from the top of your skin, all the way even into bones, into organs, into everything, you have this, okay? That's why you have millions of miles of capillaries in your body. Okay, so as the blood goes into the capillary, it's high in oxygen, but once it gives that oxygen up to the cells in the area that it's servicing, okay, it is low in oxygen and it comes back in the vein, and it's also taking along with it, besides the low oxygen, it's taking the waste products, the carbon dioxide, and it's bringing it back towards the lungs, right? So arteries go away, arteries go away from the heart, it's bringing it back towards the heart so that the heart can either pump it to the lungs or to the kidneys or to the liver to get rid of whatever the waste products are. And they actually show you in this vein a little valve, because again, once it's gone through this capillary, it's given up most of its pressure. And now the pressure, the blood pressure in the vein is very low. So if the blood pressure in the artery is typically 120/80, the pressure in the vein, you're talking between like 20 and 40, right? It's very low. So it's hard for it to travel through. That's why we have this system of valves. Okay, so any questions on the white blood cells, red blood cells, and platelets? And I'm sure everybody has lots of questions, but anything sticking out right this second? Somebody just asked a question. So hold on. So please mute, we did that. Okay. Oh, so here's a good question. Somebody who has a little medical knowledge. It says, pregnant woman, umbilical veins are oxygenated right. Maybe it's too much for the beginning. So that is true. So I don't talk about an EMT class because they'll never ask you in the state exam, but the only other vein that's high in oxygen is the umbilical vein. And we do not have umbilical veins. Umbilical veins are in the umbilical cord when you were a little baby. And since you already gave up your umbilical cord, it's the circulation of a baby from between the baby and the mother through the umbilical cord is the opposite, where veins are high in oxygen and arteries are low in oxygen. But that's not something, again, you'll ever be asked on an EMT level. But that's something you can trick a paramedic with if you want. Okay, what keeps the blood from the left, so that's probably the left ventricle, from going back into the lungs? Okay, good question. So it's the valves, right? In other words, the valves in the heart only allow blood to go in one direction. So the valves stop the blood from going backwards. So you're not going to have any blood flow, but you've all heard of grandparents or aunts and uncles who had to have valve replacement, right? So their valves are not working properly. So you could have valves that get floppy and they don't close properly. You could have valves that get sticky and they don't open properly. So there's a lot of different problems that can happen with valves. So if they get sticky and don't open, then blood doesn't flow in the right direction properly, enough blood. And if they allow blood to go backwards, then you don't get enough blood going into the right direction. You get blood flow, what they call retrograde, which is backwards. But again, that's not something we really talk about too much in the EMT class, but that is a problem. So people could tell you they've had valve replacement, okay? And that means that there was some kind of problem with their valve. They usually don't know what the problem was. They just know they had to have their valve replaced. And then the last question was, can you tell from seeing blood where it comes from? So, good question. I mean, on the test, you're going to answer, if it's bright red and spurting, it's an artery, okay? If it's dark red or maroon and flowing, it's a vein. And if it's red and oozing, it's a capillary. So that's what you would answer on a test. In real life, you'll definitely know arterial bleeding because it's basically, you're trying to get out of the way of it because it's spurting all over the place, okay? The problem is that a lot of times we don't show up right away when somebody has the wound. And arterial bleeding that has lost a lot of blood, okay, may not be spurting anymore because they've lost so much blood. So it may almost look like it's venous. So it can be hard to tell. It just really depends on how quickly you got there and how much blood they've lost to know sometimes whether it's, capillary or venous.
If this is an artery wound, and when you get that it's not spurted anymore, then he's probably AMS or unconscious.
Right. So if they've lost enough blood, very good. If they've lost enough blood that their artery is not spurting, they're not conversing with you probably. Or if they are conversing with you, they're not sitting up, they're lying down, their skin is pale, it's sweaty, and they're probably not making any sense. They probably feel like they're passing out. Okay, so I'm going to just shut the chat off for a second. Okay, so let's talk about the blood now. We said the blood has 4 parts to it. It has the fluid portion that everything floats in. That's called your plasma. So that's about 0.09% salt in water. Okay, so it's a tiny amount of salt in water. Okay, it has a slightly yellowish color to it. Okay, but it really looks like water. Okay, and most of the volume of your blood, more than half of the volume of your blood, is the fluid portion. Floating in that fluid are the 3 types of cells: red blood cells, white blood cells, and platelets. Okay, now they're going to ask you these questions on the exam. They're going to say, what's the fluid portion of blood called? Plasma. What do patients lose when they have a burn? Plasma, right? When you see a blister, that's plasma stuck under the skin, okay? So there's different ways, and we'll go over all those different questions. For red blood cells, they're going to ask you, what is the purpose of red blood cells, okay? Or they're going to ask you, what blood cell is most numerous? It's red blood cells. So red blood cells are abbreviated RBC. The old way of red blood cells were erythrocytes, okay, because erythro means red and cytes means cells, but you don't see it too much anymore. Or red corpuscles are really old. Okay, so most of the times they'll just say red blood cells or RPCs. And there's a part of the red blood cell called hemoglobin. Okay, hemoglobin is a protein to which oxygen can attach to. Okay, so you could have all the red blood cells in the world, but if you do not have enough hemoglobin, you can't transport oxygen, because the only part of the red blood cell that oxygen will allow itself to be picked up by and transported is hemoglobin. Okay. Now, who doesn't have enough hemoglobin? So really, anemic women who are anemic women are more commonly anemic, and anemia is a disease of low red blood cells. Okay, women tend to be anemic more than men because they menstruate every month. They have their menstrual period, and they lose blood. Okay, so anemia can happen to other people, but it's more common in women. That's why women a lot of times are more tired and feel weak, and stuff, especially during certain parts of the month. Okay, but again, hemoglobin is what the part of the red blood cell that oxygen attaches to. Just like I wrote it there is what you need to know. Now, you've all heard of carbon monoxide poisoning. There's carbon dioxide, which is the waste product, okay, of normal cell metabolisms making energy. And then there's carbon monoxide with an M, which is the waste product when you burn carbon gases, natural gas, wood, gasoline, anything that's what they call a carbon matter. Okay, carbon monoxide is dangerous to the body because of a strange reason why. Oxygen likes carbon monoxide more than it likes hemoglobin. So if carbon monoxide gets into the bloodstream, okay, actually I said it the wrong way. Hemoglobin likes carbon monoxide more than it likes oxygen. So if carbon monoxide gets into the bloodstream, it will coat or cover the hemoglobin molecule and not leave any part for hemoglobin to transport oxygen. So when someone dies of carbon monoxide poisoning, their oxygen level in their blood is actually very high because it can't get onto the hemoglobin to be transported to the cells. So people die of what they call hypoxia, cellular hypoxia. Hypoxia means low oxygen. Even though there's plenty of oxygen, it just can't get to where it needs to get to because the carbon monoxide doesn't let it get on the hemoglobin. So hemoglobin is the part of the red blood cell that transports oxygen. And we'll talk more about carbon monoxide poisoning. But all of you who smoke, if you were to have a blood test for carbon monoxide, you would come back with carbon monoxide in your bloodstream, even though there's no carbon monoxide in the air you're probably breathing because you smoke, and because a cigarette is burning, you're inhaling carbon monoxide amongst many other things that are killing you, right? Okay, so white blood cells are abbreviated WBCs or leukocytes or white corpuscles. Again, just remember white blood cells are the most common thing. And platelets are the part of the blood that helps control bleeding by making a clot, okay? So again, blood is made up of the fluid portion, and inside the fluid portion are three different cells: red blood cells, white blood cells, and platelets. Okay, red blood cells help with the transport of oxygen and actually carbon dioxide via the hemoglobin. Okay, oxygen via the hemoglobin, carbon dioxide just floating in the, along with the red blood cell. White blood cells fight infection, help to fight infection amongst some other things, and platelets help with clotting. Okay, when I say fight infection, there's many different parts of your body that help to fight infection, and that's called your immune system, and there's many things that make up your immune system. So we'll talk about all that at a different, not tonight, but probably the next time we meet. And something's not working here. Let's see. Okay.
Can you say something again about the platelets?
What's that?
I missed something about the platelets.
Platelets are the part of the blood we said that helps with bleeding control. Okay, it's what makes the clot that kind of closes off it makes the plug and what closes off the wounded blood vessel. Okay. It also is the culprit in a heart attack, but we'll talk about that when we talk about heart attacks. Okay. That's why we give aspirin to somebody having a heart attack, because aspirin stops the platelets from sticking together and making the clot in a heart attack. So if somebody had trauma and you gave them platelets, you would kill them quicker. But in a heart attack, if you give them platelets, you actually help them because it stops the clot from developing. Okay, so now let's talk a little bit about the physiology. We did the anatomy, a little, we talked a little bit about physiology, how things work in the cardiovascular system. Let's talk about the nitty-gritty stuff. So what is a pulse when we count the pulse? So a pulse is basically the wave of blood traveling through an artery when the left ventricle contracts. Now, obviously, the pulse, if we could feel it in the aorta, would be the strongest, but we can't feel it because your aorta is deep inside your body. So we're feeling the pulse in many different sites. We talked about, I don't know, 6, 7, 8 different sites a couple of minutes ago. Okay, where we can find an artery that's close to the surface that we could compress down on a bone, right? So to be able to feel a pulse, we have to be able to compress it down over a bone so we could actually feel the flow of the blood, okay, through the artery down onto the bone. So everybody get the concept? So is the pulse the same thing as the heart rate? That's always a good question. Is the pulse the same thing as the heart rate? The heart rate is how many signals the conduction system is sending out per minute, but does that mean the muscle is actually contracting that many times? Most of the times, yes, but it doesn't have to be. But the actual pulse is telling you how many times the heart has squeezed and pushed blood out. So what you're going to see, you know, as new EMTs is that somebody's going to say the patient's pulse rate, okay, is 100 because they put them on the pulse oximetry, the pulse ox machine, or they looked at the heart monitor that the paramedics put on, and the number is showing a number of 100. Okay, that's not actually telling you what the pulse rate is. That's telling you how many electrical impulses are going out, but to actually know how many times the heart is actually squeezing out blood, you have to feel for a pulse. And the other advantage of feeling for a pulse is you get an idea of the strength of the blood flow, right? If you're feeling for a pulse and it's very weak, the patient's complaining of that they've been vomiting or they've had blood coming out their butt or whatever it is, okay, and you feel their pulse being very weak, that's telling you something. That's telling you that their blood pressure is probably low because they've lost a lot of blood, or because they're vomiting, they lost a lot of fluid, right? So it's always good to actually physically feel for a pulse versus just using a machine to tell you, okay, what the heart rate is. So a pulse rate is different than a heart rate. Now, when we talk about pulses, we talk about close pulses and further pulses, okay? So further pulses away from the heart are called peripheral or distal pulses, because distal is further away from the heart. So they're further away than central or proximal pulses, right? So you see up here, there's peripheral pulses or distal pulses, mean the same thing, they're used interchangeably. And then there's central pulses or proximal pulses. So you know distal is further away from the center of the body, proximal is closer to the center of the body, core means the center of the body, okay? So examples of peripheral distal pulses, and they use it interchangeably, are your radial pulse in the lateral side of your wrist, right? So the lateral side is going to the outside. The brachial is the lateral part of your upper arm. Your posterior tibial is the medial part of your ankle. And your dorsalis pedis is the top of your foot. And again, I have pictures coming up in a second. And the stronger pulses that are closer to your heart, closest to the center of your body, are your carotids in the lateral side of your neck. Remember, there's 2 of them. And your femorals and the medial side of your upper thigh and your groin area, okay? Now, I think I have pictures coming up, yes. Okay, so this is some of the stuff I added today. Hold on one second, is somebody here? The bear's here? Did you say? Okay. Hold on one second.
One second. Your pet wanted to tell us hello.
Hold on. What's the matter? Okay. I think our neighborhood bear is back. Okay, so the radial pulse we said is on the lateral or thumb side of the wrist. And you see here, they're compressing the pulse, the artery down over the radial bone, which is the bone on the lateral side of the wrist, okay? The brachial artery you can feel in 2 spots. Well, actually, I put the spot in the same one. But right above the crease of the elbow on the inside of the arm, or going further up the arm by the armpit, okay? Or 2 places you can kind of feel it. It really runs coming out of your armpit down to the crease of your elbow, the inside of your elbow, and it splits, and the brachial artery splits into the radial artery that goes along the thumb side and the ulnar artery that goes along the pinky side, right? So the brachial artery comes down the inside of the arm to about here, right below the crease of the elbow, and then it splits to the radial artery that runs to your down here, and your ulnar artery that runs along here. Okay. And then the posterior tibial pulse is on the medial side of the ankle, like right down in here. And the dorsalis pedis is on the arch of the foot. They're both very, very hard arteries to find. But on the test, if they say, you know, you have a patient who has a fracture of the lower leg, where should you assess to see if the circulation is good? Those would be the answers. Basically, what we do in real life, in all honesty, is we take the sock off and we take our thumb and we just press. Remember, you have a glove on, but you press right here on the skin. The skin will go pale, and then you pull your thumb away. And if it gets pink again, you know that there's blood flow. Okay. And then the carotids are on either side of the neck. Typically, you feel the carotids, okay, on the side of the neck, and I usually go like right under the jawline, and we'll be practicing that in class. Again, we don't do both sides at the same. You have 4 blood vessels bringing blood up to the brain. You have 2 carotids, okay? And for some reason, the back ones are escaping my head. I can't remember the names of the back ones now. Nope, can't remember. But you have 2 carotids in the front, and you have 2 other blood vessels in the back of your neck that are bringing blood up to your brain, okay? And then your femoral, so this is the top of the body. Here's the nipple, belly button, leg. Here's the groin area. You can feel the femoral pressing. The femoral is coming, remember, you have your aorta coming to about here. Then you have your iliacs, and then you have your femorals coming down. So here, so you see it's coming down into about here. You're compressing it over the pelvic bone, okay? I have not felt for a femoral pulse in decades. It used to be we checked for femoral pulses when we were doing CPR to see the CPR is effective, but we have other ways of doing that now. Okay, again, central proximal, okay, are closer to the core of the body. So those are the stronger ones, like the carotids and femorals, and the distal pulses, okay, or peripheral pulses, okay, are like your wrist and your head and stuff like that. Now, blood pressure, so we had pulse, now we're talking about blood pressure. So the pulse is when you feel the pulsation of the blood, okay, when the left ventricle contracts. The blood pressure is the pressure that exists inside the tubes, inside the blood vessels. And we divide that into 2 numbers. The systolic blood pressure is the higher number, and it's when we record a blood pressure, it's always systolic over diastolic. Systolic is telling us the pressure in the arteries when the left ventricle contracts. Diastolic is telling us the pressure in the ventricles when they're refilling. So something like a normal blood pressure, let's say, is 120 over 80, or really it's more like 120 over 70 now. So 110 would be the systolic, 70 would be the diastolic, okay? That involves using a blood pressure cuff to be able to measure it, and usually a stethoscope to listen, but we'll show you some different ways of taking blood pressure. One's with a stethoscope, one's without a stethoscope, okay? And then the last thing that we're gonna finish up with tonight is the term perfusion and circulation. So perfusion, the easiest way to remember perfusion is that the cells are being fed. It's like the feeding of the cells. So when you eat, okay, you're bringing nutrients into your body. Perfusion is the cells getting everything they need to make energy. So perfusion is the delivery of oxygen and sugar and vitamins and nutrients and, you know, electrolytes and everything that the body needs, okay, to make energy. And it's the removal of the waste products, the carbon dioxide and other waste products. So picture every cell of your body, and again, there's millions and billions of them, as being a little power plant that's making energy for your body. The power plant needs something to burn to make energy. What it needs to burn is the oxygen and the sugar. And then once it makes the energy, there's the stuff that comes out, the smokestack, right? There's the stuff that comes out the exhaust, that's the waste product. That's the carbon dioxide and other waste products. So when we talk about the term perfusion, and you're going to hear it time and time again because you've heard the term shock. Well, the real term for shock is hypoperfusion, H-Y-P-O, hypoperfusion. Hypoperfusion means low perfusion. So it's not just that the blood pressure is low, it's that the cells are not getting what they need. Now, there's many different reasons why the cells could not be getting what they need, right? The person's blood pressure could be perfect. They could have the heart is pumping beautifully, there's normal blood flow, but you're choking and you don't get enough oxygen in. Okay, so the cells are not getting oxygen, they're not getting perfused. You could be having breathing perfectly, you could have a totally normal blood pressure, but your blood sugar is low. You haven't eaten and your blood sugar is low. So again, they have hypoperfusion. So the term perfusion is not the same as just the term blood flow. It's that there is good blood flow and that the blood contains what the body needs to make energy. And then if you want to go the other way, it also has to have that the body has the ability to get rid of the waste products. If everything's working perfectly and you're making a ton of energy, but you can't get rid of the waste products, you're going to poison your body. Okay. So again, it needs adequate circulation of the blood, which means that the pump has to be working. You have to have enough blood, and the blood vessels have to be of the right diameter, right? They can't be too open or else there won't be good blood flow. And you have to have enough oxygen and enough sugar, okay? And it has to be able to leave the bloodstream and get into the cells, and you have to be able to get rid of the waste products. That's what perfusion is, okay? Now, hypoperfusion is the medical term, the right way of saying shock. Shock was an old term. When there's an insufficient supply of oxygen or nutrients, okay, for the body to make energy, or you can't eliminate the waste products. And all perfusion, so if there's a test question that says, where does perfusion take place? Perfusion takes place between what two structures? The capillaries and the cells, right? Because that's where everything's going to be able to leave the blood vessels through the capillaries, the smallest blood vessels, and get into the cells to be able to do stuff. Okay, so one little question. Well, actually, yeah, well, we actually have a little more. So, sorry.
What's basically the difference between perfusion and respiratory?
Respiratory just talks about oxygen and carbon dioxide getting in and out of the respiratory system. Perfusion is saying that it got into the bloodstream and got to the cells, that oxygen that was brought in by the respiratory system got into the circulatory system, the cardiovascular system, and was delivered to the cells to make energy. So the respiratory system is the start of it. The circulatory system is the transport mechanism to get it to the cells of the body so it could be used.
And the perfusion is what changes over.
The confusion is what?
What changed everything over? What changed the waste with the good stuff?
So everything, the confusion or the perfusion?
The perfusion.
Oh, perfusion, I'm sorry. So the perfusion is when the good stuff gets out of the blood vessels, out of the capillaries, into the cells, and the cells use them to make energy, and the bad stuff leaves the cells, okay, and gets into the bloodstream to be gotten rid of for the body. Okay, so let's look at some questions. So all of a sudden, all the questions lit up. Let's see. If someone is low in hemoglobin, would their pulse be weaker? Not right off the bat. If somebody was low in hemoglobin, their oxygen level would be weaker. And if the heart did not get enough oxygen, then yes, eventually their blood pressure would be weaker. Their pulse would be weaker because the heart could not contract with enough force because the heart needs oxygen as a fuel, just like every other part of the body. So that's a good question. Okay, but pulse oximeter may show low O2 if you have a regular pulse ox, vertebral or something like that. I don't know what you're asking with that one. Whoever asked that one, you want to explain to me what you're asking?
Oh, that was me. The vertebral arteries, I think it's called, in the back of the carotid.
Oh, yes, vertebrals. Yes, thank you. For vertebrae. The vertebrals in the back of the head. Thank you.
Okay, now the other thing I was trying to say is that I don't think the pulse will be low, but the pulse oximetry, the cheap ones, will show low oxygen because it only looks at the hemoglobin, right?
Yes. So if your oxygen level and your hemoglobin is low, your pulse oximetry, which is the machine we use to measure it, should be low. Yes. Yep, that is true. But we'll talk about when pulse ox is reliable and when it's not reliable, because it's just another tool that helps us, but we don't want to be fooled by it, right? So there's sometimes where it's not going to be so reliable. Okay, why is too much sugar isn't good? Why is it a problem? So just like everything in our body, we're supposed to have a certain amount of it, and too little is bad and too much is bad. Okay, so we'll talk about that. I mean, in a person who's not a diabetic, too much sugar is not going to kill them. What it's going to do is make them fat. And then by being fat and out of shape, they're going to have other problems, right? And then also having chronically high sugar levels can cause you to become a diabetic, because what happens is your body gets used to it and it doesn't regulate your sugar, so it can cause you to become a diabetic. So, you know, you know, again, just like everything, we were designed to have a certain level of everything in our body. Remember, when we were made, there was no such thing as cookies and cake, right? And stuff like that. There was no such thing as sugar you added to food, right? So this is all stuff that the body had to learn.
For a reason. They introduced the cookies and cakes for a reason.
Yeah. I don't know. Yeah, you know why? Because our brain, sugar is like a drug to our body. So our brain craves it. So once we learned about it, our body craved it. Okay, so let's look about some of these questions here. How is the function of the respiratory system related to the function of the circulatory system? So I don't know if that's a great question, but basically what we need to know is that we can't have one system without the other. So we have to have the respiratory system to bring oxygen in and remove carbon dioxide. And we have to have the circulatory system to take that oxygen and transport it to the cells and to bring that carbon dioxide from the cells and get rid of it, right? So basically you can't live with having one system and not the other. They both have to work, and they're both dependent on each other to stay alive, okay? Interaction of the respiratory system, the cardiopulmonary system. So again, that's what we just described. Perfusion is that the cells get the oxygen and that the carbon dioxide is removed from the cells. So perfusion is the feeding of the cells. The cells get the oxygen, the sugar they need to make energy, and that waste product of making that energy is removed from the body, okay? So that's what
and hypoperfusion is that the cells get the oxygen, but it's not good?
Nope. Hypoperfusion could be many different things. But basically what it is that it's saying that the cells are not getting what they need. It could be that they're not getting enough blood flow, or it could be that they're getting plenty of blood flow, but the blood doesn't contain oxygen, or they could be getting good blood flow, it doesn't contain enough oxygen. So it's a little complicated, but the term perfusion means it's getting everything that it needs. Hypoperfusion means it's not getting what it needs, but then we have to investigate and find out what it's not getting. So let's say somebody starts to bleed now, right? Prior to bleeding, they were breathing fine and they were eating fine. So the problem, their hypoperfusion problem is going to be what? They have plenty of sugar and plenty of oxygen in their body, but they start to lose blood, so they can't circulate that oxygen and sugar because they don't have the fluid that's going to travel it. Or somebody's eating right now during class and they start choking on food. So they have plenty of blood, their heart's pumping fine, but they're not getting oxygen in. And eventually, because they're not getting oxygen in, the heart's not going to get enough oxygen to beat, so their blood pressure is going to start to fall. So everything kind of is interconnected. But the overall term perfusion means that the cells are getting everything they need to stay alive. On our level, the main things they're going to need, okay, is that they need oxygen and sugar, and they need to get rid of the carbon dioxide and other waste products, okay? So that's why I'm crying. Why wasn't there cookies and cake? Okay, that's the one bad thing about COVID. On Thursday night EMT class, we used to have a pre-Shabbos Kugel and Cholent cook-off contest, and it was actually a very good class. Okay, so one last thing, metabolism. So perfusion is the feeding, metabolism is the burning, okay? So you all heard people say I have a slow metabolism, that's why I'm fat, and some people say I have a fast metabolism, that's why they're skinny, right? So metabolism is the rate by which the cells, and we said the cells are kind of like the power plants, the cells burn up the sugar and the oxygen, right? So if you have a fast metabolism, it burns through it very quickly, and if you have a slow metabolism, it burns through it very slowly. So when they talk about metabolism, they're talking about the rate by which we burn up the good stuff to make energy, okay? And we have two types of metabolism, and this is a little confusing, so we're going to go over it next week again. But the good metabolism, okay, is called aerobic metabolism. So you've heard the term aerobics when people exercise and they're jumping all over the place and they're burning a lot of calories and they're out of breath. Aerobic metabolism is the way we normally make energy when we combine oxygen and sugar and burn it to make energy. It's the best way to make energy. We make the most energy. And the other thing that's important is that the waste product, byproducts and waste products are the same thing down here where it says byproducts and waste products, are carbon dioxide and water. And those are very easily removed from the body. Carbon dioxide we exhale, water we reuse or we urinate out, right? So that's the way God decided we should make energy, is aerobic metabolism. We make a lot of energy as long as we have sugar and oxygen, and we're able to get rid of the waste products very easily. So that's the ideal way to make it. Now, when you don't have, okay, good amounts of oxygen and sugar, you go to a other form of energy called anaerobic. So remember I said if there's an A or an AN in front of something, it's the opposite. So you see here, it's aerobic, A-E-R-O-B-I-C, and here it's anaerobic, where the AN is in front of the word. Now we're making energy, okay, without enough oxygen. Why is there not enough oxygen? We don't know. Maybe they're not breathing well. Maybe they're choking. Maybe they're breathing fine, but there's not enough blood flow to bring that oxygen. Maybe they have carbon monoxide poisoning and they're breathing fine and there's plenty of blood flow, but because of the carbon monoxide, the oxygen can't get on the hemoglobin. So for tonight, we're not going to be able to totally understand that. But, you know, there's many different reasons why you're not going to be able to get enough oxygen. It's not just because you're not breathing well, okay? Now, when you have anaerobic metabolism, the problem is you still make energy, you just don't make enough of it. And the waste product is something called lactic acid, L-A-T-I-C. I'm going to talk about it later, lactic acid. You've all experienced lactic acid. You've all experienced, obviously you've all experienced anaerobic metabolism because that's what we're doing right now. But you've also experienced anaerobic metabolism. So you were walking, you went to Miami in the winter and you were walking on the boardwalk, okay, fast, because you wanted to burn some of that cookies and cake that you've been eating. And while you were walking on the boardwalk, you got pain in your side, okay? It all happened to us, right? We got pain in our side. So what was that? We noticed that when we slowed down, the pain went away. So what happened is you were walking so fast and you're out of shape that you started to revert from aerobic metabolism to anaerobic metabolism, okay? That you were using your muscles too much and they were not getting enough oxygen, okay? Because you were walking fast and all of a sudden you started to get a burning or painful sensation, and that's the lactic acid in your muscle. Or maybe you were changing a light bulb or you were changing a light fixture and you're standing on a ladder and you have your arms above your head and you're trying to work. And after a couple of minutes, your arms started to shake and they started to burn and they started to get heavy. Okay, what happened? Because your arms were higher than your heart and above your head for a long period of time, you weren't getting as much blood up to your arms. And because you weren't getting as much blood up to your arms, you weren't getting as much oxygen up to your arms. So the cells in the muscles in your arms changed from aerobic metabolism, which is making the energy the right way, to anaerobic metabolism. And again, you had that lactic acid that developed and you started getting shaky and started getting painful and you may have felt a burning sensation. So it's all happened to us, but the difference is that we can reverse it because we had no major problem, right? I mean, you know, we slow down our walking or we lower our arms and everything goes back to normal. Now later in class, we're going to talk about conditions where something went wrong in your body and it's not going to be a simple thing to reverse it. Now we know we have ability to sometimes correct things. If somebody's oxygen level is low because they're having breathing problems, well, we can give them oxygen. If somebody's choking, we can help clear their airway, right? So there's certain things that we may be able to help patients with, but obviously there are things that are beyond our capabilities as basic level EMTs to be able to help. And sometimes it's even beyond our capabilities as paramedics to help, and they need a hospital and doctors and, you know, more advanced care, okay? So perfusion is the feeding of the cells with what they need to stay alive. Metabolism is the rate by which they burn that food, okay? So the good metabolism is when they burn the sugar and the oxygen to make energy, and the less good or the not as good metabolism is called anaerobic, where they don't have enough oxygen, okay? They still make energy because they still have sugar, but they don't make enough of it, and the waste product is something called lactic acid. Okay, so I think I fried you guys' heads for the night. Okay, so it's 10:27. It was a lot of information. Okay, we're, I would say, halfway to maybe 60–70% done with the anatomy and physiology. Probably the next hardest part is the brain and the nervous system. Okay, so we probably have 2 more nights of this. We'll have, you know, maybe tomorrow night, and then next week we'll do 1 more full night and then maybe 1 night of review, and then we're going to switch on to the different airway skills that we'll learn to do to help people. Okay, so we have probably another week or so of the hard stuff of how the body works. Then we'll have some easy stuff. We'll talk about, the different airway procedures we do to help people, oral airways, nasal airways, bagging people, and then you'll have some skill sessions and stuff like that. Okay, so before we call it a night, anybody have anything that's really confusing that you want to go over tonight? And if not, we can, you can text me and we'll go over it tomorrow and stuff like that. As people start asking really good questions, I'll put it up either by email or WhatsApp, because some people don't have WhatsApp. Good.
Could you post on WhatsApp which pages to read from the book?
It's chapter 6, Anatomy and Physiology. I don't know the exact page numbers, but it's the Anatomy and Physiology chapter. Somebody has the book in front of them and they could tell them the pages. That would be good. Or put it up on WhatsApp.
It was all in the original email.
Yeah.
The page numbers and the chapters.
Okay. Yeah, I don't have,
From 111 to 149 to 150.
Okay. Okay, so any questions? Anything we want to go over? I know everybody's pretty fried. Okay, so
I wonder what I could do to convince you to start going to classes in person.
Why? I'm not doing a good job by Zoom?
Doing a great job.
Okay.
For me personally, it's going to be better if I'm in person.
We'll see. Let's see what happens as the months go on with COVID and everything.
Some cookies and cake.
It's not cookies and cake. I'm already too fat. So.
John.
I don't even know if you're fat or not. I can only see your face.
I want to see you live.
Frank, if you're coming on Thursday, I'm throwing on Sean's body.
When can I drop off the cookie?
Okay. So what was the kugel that won me over? Yapchik. So one class, some guy comes up and says, I actually always started out the contest with making my own cholent, and so one guy says, next week, he goes, my wife is making yapchik. He goes, don't bring anything, it'll be enough, trust me. I was like, okay. So I didn't really trust him, so I made a cholent anyway. And he brings in these huge pans of this, looks like this, mushy potato kugel. I'm like, oh, forget about it. Nobody's gonna like this. And within 10 minutes, there wasn't a scrap left, and everything like that. So
This time there might be a tight race because we have a party planner in the group.
I actually pulmonary yapchik.
Okay, so everybody have a good night. Get some rest, and we'll see each other tomorrow night. Okay.
Thank you. Good night.
Good night.
Good night. Thank you.
And I'll post a recording as soon as it's done. Take care.
Can you post her on Dropbox?
I haven't figured out how to do that yet.
Oh, you gotta go back to school then.
Yeah, I know. I'll try to work on that tomorrow and see if I can put it up on Dropbox.
What date is next week, class?
I believe I put it out already. I sent out the invitations. I think it's next Tuesday and Wednesday again next week.
That's correct. Tuesday.
Yeah, the other thing too that we could talk about while everybody here is Motzei Shabbos. I'm not going to say that we're going to have class on Motzei Shabbos unless we really need to, but if people want, after this Shabbos will be ending early. If people want, say 9 o'clock-ish, 9:30-ish or whatever, to maybe do an hour, a review. It'll just be, if you want to come, we'll do it. I'll sign on for an hour or so, and we could do like an hour of review, 9:30 to 10:30 or something like that. If I get a nap in, maybe 10 to 11, we could do an hour of review of what we covered or any questions anybody has, just to help, clear things up. Okay, so not for this week because Shabbos is still regular time this week, but the following week Shabbos will be out earlier. Okay.
I want to know what the best way for a diet.
What's that?
What's the best way for a diet?
No, you don't want that.
Best way for a diet is, first of all, make sure you're walking and you're not sitting for more than, say, 30 minutes. And then don't eat after dinner. Whenever you finish dinner, that's it. That's how you start. And then we'll go from there.
If you do Motzei Shabbos, it's not going to be new things, right? It's only a review?
Yeah, so Motzei Shabbos, unless we're really falling behind, and I'll tell you that in advance, Matzah Shabbos will only be review. We won't do new things that we have not covered. Okay.
Thank you.
Because I know some people don't want to do a Matzah Shabbos, but I just
Yeah,
have to
some
tell
people
you.
have issues with the Yapchik and the Cholent Matzah Shabbos.
Can I post this on YouTube also, yeah?
Yeah, that's true. Actually, I should have stopped the recording. Thank you for reminding me. Okay, so everybody have a good night, and we'll pick up again tomorrow night, okay?